flow will be like this. Every speaker will have 12 minutes for his lecture or demonstration of surgery with 3 minutes of discussion. We have eminent faculty across India. We have 3 moderators. Dr. Sridhar from, he is there. Hi Sridhar. Sridhar, can you hear me?
Yes, I can hear you.
Pankaj Valecha, are you there? I think he is about to log in. And Dr. B.R. Bagadia from Jaipur only. Here I just want to have the opportunity to introduce my faculty one by one. We have, hi Dr. Jaya, we have senior most Dr. Raju Ishwaran. He is very dynamic and academician. He is very active in our IS society also. He's working in Delhi at Shri Meenakshi Orthopaedic Sports Medicine Clinic. I think he's running his own clinic. We have Dr. Deepak Joshi. He's going to speak on ACL with lateral tenodesis or anterolateral reconstruction. He's working in Safdarjung Hospital with the Sports Injury Center. All we know his credentials. We have Dr. Rajiv Raman from Calcutta. He is also interested in knee surgeries. He working in the Kamini Hospital. Dr. Jaya, he is going to speak on osteotomy. He is from Hyderabad. And after that, we have our previous presenter, Dr. Roshan Wade from Mumbai. And last but not the least, one of the most active and dynamic surgeon, Dr. Prathamesh Jain. He is going to speak on patellofemoral instability. One of the most active and dynamic. Let's start. I think Sridhar, you can invite first speaker, Dr. Deepak.
Yes, sir. Good evening, sir. Good evening, everyone. So I think we'll start off with the first talk by Dr. Deepak Joshi. He's going to talk on ACL reconstruction and lateral tenodesis. So Deepak, sir, over to you.
I welcome Dr. Ashok Sham. He is there. Our this webinar is live on OrthoTV. Thank you, Dr. Sham.
Everyone, am I audible?
Yeah, we can hear you.
We can hear you. We can hear you.
Yeah. So I again thank you everyone, Rajiv and all the moderators for inviting me to this wonderful platform, and it's very good to be with friends. Always wonderful to have here. And so I would be speaking on the topic ALL, the anterolateral ligament, or the lateral tenodesis that we do sometimes in our cases. So why this ALL has come into picture? Because a subset of patients experience some residual AP laxity and the rotational instability after the reconstruction. So one of the study published in 2015 Orthopaedic that showed that there are some structures on the anterolateral aspect of the knee which actually prevent or give some rotational stability to the patient. So we, in a high grade pivot shift patients, there is a risk to injury of this particular ligament, and which led us to the anatomy and discovery of this ligament and the function of this ligament. So in this study, the Clays et al. Concluded that AL is a very important internal rotatory stabilizer between 30 to 90 degrees of the flexion of the knee, and the ACL is limited to mainly anterior tibial translation, though we know that definitely ACL is important for pivoting as far as we are concerned. So they sectioned the anteromedial bundle and the posterolateral bundle and grade of the pivot. The pivot came out to be grade 1 positive, but if the pivot is grade 2 or more, they saw that it happens only after the sectioning of the AL. So ruptured ALL is prerequisite for the grade 3 pivot positive in ACL deficient knee. So what is this ALL? ALL, as you can see on this picture, ALL is a fan-like, it's a big ligament starting from the femoral epicondyle, going superior to LCL and going down to the Golgi tubercle area, somewhere midway between the Golgi tubercle and the LCL. It's a thick ligament, it's thick capsular fold that is seen on cadaveric dissections. So they saw that it comes under tension during the internal rotation of the knee at 30 degree of flexion. It's a non-isometric ligament, quite a big ligament from approximately 4 centimeter in length, about 7 to 8 millimeter in wide, roughly very thick, about 3 millimeter thick. So it's an important thickening of capsule, or you may say it's actually a ligament that prevent the provide the rotational stability of the knee. So if you go by the history, the Paul Segond has described this fibrous band quite early in 1879, and according to him, the Segond fracture is basically the avulsion fracture of the LCL attachment of on the tibial insert. So according to him, some band on the tibia is that goes. It's probably an anterior band of LCL that gets injured, and later it is called by different name, maybe anterior band of LCL, anterior oblique band, and now it is well known and defined as an anterolateral ligament. So Ferretti et al. Classified into type 4, 1, 2, 3, 4. In the type 1, there are some microscopic hemorrhages only. There is no rupture to the ligament. Some anterolateral capsule injured. Type 2, it's a multiple level injury to this ligament. You can see a macroscopic hemorrhages. Plus AL and PL capsule is there. Type 3, the ligament is completely torn. And type 4, we have a Segond fracture or the bony avulsion. MRI is with a 3 Tesla and 0.4 millimeter thickness fat suppressed image. You can identify the ALL easily nearer to the meniscal and the tibial attachment, as it is very, very proximity in relation to the LCL and the popliteus tendon. So when we do ALL in our cases, so whenever there is a grade 3 pivot in an athlete, contact athlete, high level athlete, one should always do an ALL. And in revision ACL surgery, if the patient comes to you with the normal ACL tunnels, with a injured with a maybe very insignificant trauma, so probably there is something that is causing the problem to the patient. So when you revise this patient, you should do an ALL along with it. Post-ACL reconstruction, symptomatic patients with clinical residual rotatory. So you have the ACL is normal, well-placed tunnel, the MRI it's quite healed, and still the patient saying some pivoting, some anterolateral, some instability is there. So we have done in some cases like them also. So the lateral tenodesis, so they do well after the reconstruction of this ligament. So the main concept of the ALL, we can use an ITBP, the tenodesis thing, or we can use this MET or the gracilis graft. Since we know that the PL bundle also provides pivoting, but it's in a double bundle, but it's a more central sort of a location, is more central to prevent that much of pivoting. So since the ALL is peripherally located, so it's a main contributor to the rotational stability of the patients. So various surgery has been described. So we earlier, when the ACL was not that popular, so many check ligaments we used to make. Like Lamere procedure is one of the procedure which was very, very popular, and it has come again. It has become modified Lamere has become very popular these days. So ACL is a primary resistor to the ALL. Internal rotation of tibia is less than 35 degree, but when it is more than 35 degree, the ALL comes into the picture, and it prevent the internal rotation of the tibia on that. So this is a picture, a strip of iliotibial band, Lamere. Actually, it is detached proximally. It passed deep to the fibular collateral of the LCL ligament. And it is passed deep to the FCL second time again. So we can see in this picture, this is an original Lamere. So a curved hook is passed, and the graft, the IT band is passed on the second time, and fixed to the sutures with the knee flexed in 30 degree and held in external rotation. So I lost my pictures because of I crashed my laptop. So this is courtesy Rajiv. So this is how the modified Lamere technique that we use. So we take a strip of the IT band, you can see in the first picture, detach it proximally, leave it inserted onto the gluteotubercle distally, and it on the second picture it passed deep. You can see the artery going deep to the LCL, and it is taken through the LCL, and it is fixed onto the lateral epicondyle with a screw in 30 degree of knee flexion. So this is again a small video from cadaveric video from the arthrex. So you can see he's marking. This is the classical AL on a cadaver. How we do it. So we mark a point in between the fibula and the gluteotubercle. So that's what he's showing, the gluteotubercle anterior and the fibula posterior. We mark the point in between the two, and the other point is onto the lateral epicondyle. The gracilis is harvested here. Proximally, the incision is made deep, and another incision is made. So you can see the gluteotubercle anteriorly with an index finger and a thumb posteriorly onto the fibula, and we can see the plane is dissected, and the graft is then passed. So we can use a retractor. If we use a small incision, we palpate the epicondyle, so lateral epicondyle, and we pass a guide wire over it, remade with 4 millimeters. So the guide wire is passed onto the epicondyle, and we remade with the 4.5. So you can see guide wire is passed, and just little bit of pass forward. So we remade with a 4.5 up to 2 to 3 centimeter, and pass a swivel lock anchor along with a graft. So that's a gracilis going in with a swivel lock anchor. So that's how it is going inside, and then it is passed, the graft is passed deep to the IT band. So you can see, so that's a swivel like coming. You can see the graft here, graft inside the bone, and the artery, the hemostat is passed deep to the IT band, graft is passed through deep to the IT band, and the guide wire is put in between the gluteotubercle and the fibular head, which is between the LCL and fibular head. And this is how the isometry checked. The graft is wrapped around the wire, and the isometry is checked that the graft, there is not too much of tension on the graft on flexion and extension. And finally, we ream and put another swivel lock. So here the Y swivel lock is being put. So in 30 degree of knee flexion, this is how the ALL is fixed. So there are other procedures also has been described. You can see the arrow. This is a McIntosh procedure in 1976, where the check ligament of the IT band, similar to the proximal, it goes through deep to the LCL, comes through the osteoperiosteal tunnel adjacent to the lateral head of the gastrocnemius, turned back and stitched back onto the itself in 90-degree flexion, held in external rotation. Another technique, loose technique, similar, in which the tunnel is drilled in the femur from anterior to posterior. The graft is going deep to the again LCL, comes back, and it is stitched back onto the gluteotubercle at 30 degree in external rotation. So there are so many techniques there, but I think the modified Lemaire procedure has become very, very famous this time. So Ellison technique, again a distally strip of IT band passed with a bony flake, passed deep to the HCL and anchored onto the. So here he is taking the bone and advantage of fixing the bone, bone to bone, trying to promote a bone to bone healing. So another technique here, it is going deep to the LCL, deep to the tendon of the gastrocnemius, and it is brought back and stitched. So there are so many techniques there described in the literature. I think another technique, Marcesi and Zeffrigani technique, here he is try to make both the ALL as well as ACL. So ALL, the tendon goes, semitendinosus goes into the joint and turned around the over the top position, brought back and stitched back onto the guidatubercular, basically bit space between the guidatubercular and the fibula, and fixed in 90-degree flexion in external rotation. So anterior ligament repair augmented with suture tag, that already shown. The indication is the acute ACL surgery where you can put in severe pivot shift, high risk athletes. Advantages are you actually repair the ALL, repair of ALL instead of reconstruction, biological healing of ligament, internal brace can be allows early post-op rehabilitation, less pain, but definitely second incision is required. So to conclusion, the concept of anterolateral laxity and the anterolateral tenotosis for ALL is now well known and well accepted among the orthopedic surgeons, the arthroscopic surgeon. Although isolated lateral tenodesis are obsolete, we don't do just alone. It is generally done along with the traditional ACL reconstruction. So we still, whether long-term, whether it will cause some arthritis or increase pressure onto the lateral joint, and maybe, but it's not known. I think it is still more debatable. But one thing is for sure, that there are small subset of patients, as were discussed earlier, they do require this type of reconstruction for allowing the giving the rotational stability to these patients. So I think more RCTs will come and they will tell whether these conditions, these techniques do any harm to the knee or not. But definitely the short-term studies show that they are definitely beneficial in small subset of patients. Thank you so much.
Thank you, Deepak sir. Just I want to put questions to all faculties. In isolated ACL tear with high-grade pivot, how many of you do nowadays ALL? Just one by one we can have comments, or start with the Dr. Raju.
I almost never do a lateral sided procedure.
You never do?
Almost never do a lateral sided procedure. In a high grade pivot, I prefer to take either the bone patella graft or the quadriceps with a bone plug. I mean, it's just a way of thinking. In my hands, it has worked well, and I've never felt the need to do anything on the lateral side so far.
Dr. Rajiv?
I agree with Dr. Raju. In one or two revision cases, I have done ALL reconstruction also associated, because when it was a high-grade pivot and failure of ACL reconstruction, ACLR, then in those cases, I have done in 2 cases lateral side reconstruction.
Fast. And Dr. Vivek, what about you? You believe in this philosophy?
I think we have come a full circle. We started from extra-articular, then we went to open anatomic, then transtibial, then arthroscopic anatomic, then addition of extra-articular. So it's like a fashion. We have come back to the bell bottom. The thing is, I still don't do it, primarily, and I do it only in revision cases. So revision cases, yes, but not in the primary cases. Certainly not.
Okay, Dr. Jaya, what about you?
Yeah, I do all my pivot shift grade 3 cases and revision cases. And on table, if it is, I have a doubt after giving anesthesia, if someone don't have the pivot shift in OP, but on table, if I have a pivot shift, explosive pivot shift, I do, definitely I do OLL.
Okay, fine. Dr. Prathamesh? Dr. Prathamesh?
Some network issue is there. Prathamesh is not.
Dr. Roshan, sir, yes, are you there?
Yes. Can you hear me?
What about you, sir?
About the doing ALL or doing lateral extra-articular tenodesis, I think these are 2 different philosophies altogether. But whenever we have a grade 3 pivot shift and explosive pivot, what has been described by many, as when you have a complete pivot shift of the knee joint, unless it is associated with some other reasons like root tear or ram tear or the lateral collateral ligament or SCL injuries, I always consider the lateral extra-articular tenodesis, because this one surgery is going to preserve my ACL for further damage. So I think.
Okay, fine. And okay, fine. Dr. Sridhar?
I don't do any lateral procedure.
So out of our 8 faculties, 2 believe in this lateral procedures, the rest of don't believe. And now my question to Dr. Jaya, what do you think about ALL reconstruction and lateral tenodesis? How you find it different? And Dr. Deepak, my also question to you, how do you see lateral tenodesis versus ALL? Which one is better, and does it really matters in the clinical practice?
See, most of the time I do a lateral tenodesis, but classical ALL, I think I've done 1 or 2 cases only till now. And I think the lateral tenodesis does well. One thing is that you don't have to take an extra graft in our country, where the autografts are very, very important for us. We can use an IT band for that. And the other thing is that the cost becomes very, very less when we do a lateral tenodesis. So we use it's very difficult to believe. I never used to believe that this thing will have. We used to do lots of double bundles. 50% of the cases, that we used to double bundles, and we saw that our philosophy was that the PL bundle is the one that will prevent the rotatory instability, in the explosive pivot shift, it will help. But that bundle used to stretch out eventually. So that's why we stopped doing. The number of double bundles has gone down much. And this procedure has done very well, even in the patients where the ACL is absolutely normal. We have done the ACL, but the patient is showing that, no, I am having some rotational stability. So we did an isolated lateral tenodesis only in them, and they are doing quite well. So that is the experience that we are getting right now. I think over some years we will have a clearer pictures, but definitely this.
And I agree with Dr. Deepak Joshi's statement. Even with intact ACL, some patient shows you anterolateral rotatory instability on your clinics. I do in few cases with high grade pivot shift test. From last 3 years I am doing this, and it's okay. No issue with the restriction of movement. One question more with Dr. Deepak Joshi. If you find any lateral meniscal tear and you do lateral meniscectomy, still you do with lateral tenodesis, as there is a concern regarding lateral compartment tightness and later on arthritis. What do you say about this?
This is that is being associated with that classical ALL. I think when we do a lateral tenodesis, probably the pressure may be less. But definitely a lateral meniscectomy, this is again a two-edged sword. We cannot give leave the knee unstable to these patients. So in the revision cases where we have already done the lateral meniscectomy, or it's already there, definitely there is some pros and there is some cons, and we must explain all these to the patients. So the tunnels are normal, the ACL is normal, and in the revision, and we are revising it. I think we should add, and I think more RCTs will tell us whether the arthritis really developed.
Okay, fine. Thank you. Any questions, Pankaj? You want to ask any question? And faculties, you want to put any comment on this?
There was a very interesting paper by Volker Musal, who have published, I think, the only clinical study after doing a lateral extra-articular tenodesis. They showed that the lateral ligaments stretched out eventually, and it made no difference at all to the pivot shift. So the jury is still out. I am presently not convinced with the existing evidence to do something additional on the lateral side.
Deepak?
Yeah.
So you, how do you anchor this, the IT band strip? Do you actually make a tunnel and then you go to the modified Lemire type, or you just use a staple?
No, we put a screw inside the.
So then how do you prevent these tunnel coalescing Do you?
So that is very important when do we do an LCL. So the direction of the tunnel is proximal and distally. That's how we make, and we always check the before putting the graft. We make the tunnel, and we before putting the graft again, we check whether there is any collision. So if we direct the tunnel anteriorly and proximally, I think there is no interference that we have seen.
Okay.
Again, we are not doing that many cases. We are only very, very selective in doing these cases where really it is.
Okay, thank you.
Vivek sir, though it will be in your revision case, how frequently you do in revision cases scenario? Do you believe in?
Will be something like once in 6 months.
And what about lateral procedures in that scenario?
See, lateral procedure I hardly ever do in an isolated ACL. Maybe one reason is I'm not operating on a very, very high demand people. Number one. Number two, as I think Roshan said, in a large majority of the patient where you get explosive pivot shift, it is often the root tear which causes the explosive pivot. Okay, so the minute you have taken a good graft and you have put stabilize the root, the explosive pivot shift goes away. So I do it only on the revision cases, not in the primary. Unless and until somebody is a very high demand athlete, he has got a ligament laxity, hyperextension about 5 to 10 degree, there I'm a bit scared about it stretching out, then maybe yes, but as Raju said, we still don't know. And Deepak said maybe in another 5 to 10 years we'll come to know whether it really is required or not, when lot of volume of the data will be available.
Yeah, true. Though in 2018, ISAFOS has lot of literature, lectures, and video techniques on lateral tenodesis and lateral procedures. Sridhar, we can invite our next speaker.
Yeah. So we'll go to the next talk by Dr. Raju Ishuran from Delhi. So he'll be talking on PCL and the multi-ligamentous injury. So over to you, sir.
So good evening, everyone. Are you able to see my screen and are you able to hear me well? Yeah, wonderful. So I'd like to begin by thanking Dr. Rajiv and the organizers. This perhaps has to be the very first time that I'm attending this course without the traditional kachori of Jaipur, but then the virtual times force these things on us. So I'll first start by giving an overview of management principles of multi-ligament knee injury. And if the moderators then allow, I'll quickly present 1 or 2 cases to highlight these principles. So when it comes to multi-ligament injuries of the knees, I like to classify them using a simple classification known as the KD classification or the Schenck classification. So single cruciate intact knee dislocations, that is a PCL intact knee with a torn ACL and PLC, these have low risk of neurovascular injuries. Then you have the KD2. KD2 is a bicruciate injury with intact collaterals. This is a relatively rare injury. And then a bicruciate with 1 collateral. These can be further classified as KD3M, in which the medial side is gone, or a KD3L, in which there is a lateral side injury. Medial sided injuries are far more common than lateral sided injuries. Rarely you also get all 4 ligaments torn as a consequence of a very high energy injury. Fracture dislocations again are classified similarly depending on the number of the ligaments torn. ACL and PCL avulsions are excluded. They are classified as ligament disruption. In some special circumstances, the term C, alphabet C, denotes vascular injury and N denotes neural injury. Now, the initial management when the patient comes to you in an emergency situation obviously depends upon the estimation of vascularity. And the best way to do that is serial estimation of pedal pulses. Because it is known that non-flow limiting intimal tears, they do not progress to full occlusion. So there is no need to use the ankle brachial pressure index because it requires special equipment. And it's unreliable in elderly people, in diabetics, and in hypertensive. And the cutoff line of ABPI is also controversial. The role of angiography is quite selective. It's based purely on clinical judgment. Just like in a fracture scenario, it is important to understand the personality of the injury, and the best way to do that is through a thorough clinical assessment. And the important things to look for in inspection are ecchymosis and dimples. Ecchymosis sometimes can be the only indicator of a PCL or a medial collateral injury, and a dimple can sometimes indicate an irreducible dislocation. I like to do a simple Lachman for ACL, a posterior Droyer for PCL. On the medial side, I like to look at valgus stability at 20 to 30 degrees and at full extension. On the lateral side, similarly, varus stability at 30 and assessment of external rotation at 30 and 60 degrees for the popliteus. It is important to look at the lateral popliteal nerve by checking for the strength of foot eversion, ankle dorsiflexion and toe extension, and also to look at the autonomous zone of the common peroneal nerve for sensation. When it comes to imaging, both the X-ray and the MRI are required. It is, of course, useful in such circumstances to always remember medial-sided anatomy, and the excellent anatomical works of Dr. Rob Leprard and his group are useful references in this regard. So I always have these charts in my theater so that I can be reminded intraoperatively of what I'm actually dealing with, because these structures don't look that clean when you operate upon them. It is again useful to have a good idea of the radiological anatomy, especially if you want to use a C-arm intraoperatively, or maybe in a post-op scenario where you want to assess how well you have done the surgery by looking at the tunnels. Similarly, you can see the lateral structures on imaging, both on the X-ray, and you can use the same knowledge to assess your lateral side tunnels on imaging. And it is important to know the anatomy of the fibular head. You don't need so many, you don't need to remember so many attachments. If you just manage to remember the attachment of the fibular collateral ligament and the popliteal ligament, that should be more than enough. It is very useful for lateral reconstructions. The current evidence overwhelmingly favors surgery for managing multi-ligament injuries. Immediate surgery is advocated for irreducible dislocations, or if there is any vascular injury, or if it's a compound or an open dislocation. Early surgery is advised for avulsion fractures or KD5 injuries, or if some kind of a delay has been imposed due to a plastic surgery or a vascular procedure, or if the patient is obese, or if otherwise the soft tissue condition is not considered to be good. Now, when it comes to surgeries, there are multiple controversies, and I'll just try to address them one by one. Splinting the knee dislocation of the multi-ligament injured patient is best done with a small posterior pad kept beneath the calf, the upper calf, so that the tibia can be translated anteriorly to maintain the normal tibiofemoral step-off. A more expensive way of doing this, and perhaps a better way of doing this, is to use a dynamic PCL brace, and if time permits, I'll present a case which demonstrates the successful use of this brace. Plaster cast is no longer in vogue. The use of external fixator may be considered when the injury is open, or if there is a vascular injury, and if the knee is very unstable, just for initial fixation. Now, when it comes to surgery, open surgery is recommended for collaterals and coroners, and arthroscopic surgery is recommended for cruciates. And sometimes it is useful to remember that even the cruciates can be handled by open surgery, which again I'll try to show through some case examples. The timing of surgery, early surgery is better. Now, when it comes to KD2, the time is 2 to 3 weeks. KD3 injuries, again 2 to 3 weeks, in some instances between 3 to 6 weeks as per these published guidelines. Graft, we have a shortage of graft, as was previously addressed by Dr. Deepak Joshi. And one graft which can be considered in this scenario is the peroneus longus. It's a good, robust graft, and it can be used especially to reconstruct the PCL if you want to use the hamstrings for the medial side. In case all four are gone, I first like to tension the PCL, then the ACL, then the lateral side, and then the medial side. The rehab goes in a very slow manner. I like to splint them in extension for 4 weeks, non-weight bearing for 6 weeks, a prone range of motion. The only exception is if I've given a dynamic PCL brace, then I would like to allow a supine range of motion. Otherwise, it's a prone range of motion. I advise my patients to use the brace for at least 6 months, roughly till a year. And it is always advisable to let them do a co-contraction of quadriceps and hamstrings to prevent shear stresses across the repair. Strengthening exercises after 6 months, and return to sports roughly at the end of a year. So to summarize, the things to look for are pulse, routine clinical palpation, and angiography on selective grounds. For diagnosis, it's mainly your clinical assessment. Intra-op stress X-rays are something which can be used. And surgery is the preferred method of handling them early on. You try to repair collaterals and reconstruct cruciates with an open mind as well. You can do these structures very well in an open surgery as well. Thank you very much indeed. And if time permits, I'll just show one or two cases based on the principles which are just discussed. But in case there are any questions on this talk, I'm happy to take.
Sir, you can go ahead with your video, short video on any one case related to multi-ligament. Then we will have questions.
Surely.
Meanwhile, just before putting your case, I just want to ask you, what do you mean by selective angio?
So selective angio is when serial estimation of pulses makes you suspicious. The best way is to serially measure pulses over the first 24 to 48 hours. If you or if your resident feels that the pulse is feeble in a multi-ligament injury scenario, do not hesitate to undergo an angio. You don't need a proper dye angio these days. MR angio is good enough.
Just reframe my question. If a patient comes to you after 3 days, 4 days, and 5 days, do you think this patient may require angio? Because sometimes there is a paper on delayed thrombosis. Thrombosis when there is an intimal tear.
Correct. So it's a very valid question. And my answer to that would be, I would probably not consider angio in such a situation. Because it is known that intimal tears, they do not progress to full thrombosis. And if a person has survived the first 3 days with a properly vascular limb, I do not get this angio done, neither a dye angio nor an MR angio.
Rest of faculty convinced with the same?
Can I come in, Rajiv?
Yeah, sure.
Rajiv?
Yeah.
I may agree partly with Raju, partly not, because we have done a study, we are yet to publish that, and in a tertiary level center, we have observed the delayed vascular injuries, especially in the knee dislocation cases, where you can get a delayed thrombosis because of intimal damage. And for that, we have come up with a new protocol, that is KM protocol, where always all cases who are involved in multi-ligament injuries, that means more than 2 ligament injuries, we always do a diagnostic angiography as a part of protocol, because sometimes it's that 10 minutes investigation can save your life and you can give you more and more information.
That's very nice, Dr. Roshan. I'd be very keen to read this study. And as you are celebrating your birthday, I'll agree with everything that you say. Happy birthday to you.
Happy birthday. Yeah.
No. Second reason is, we have studied the few vascular patients who have undergone surgery at our center. And post-operatively, when we had done an angio, we realized that this patient had the vascular injuries with thrombosis, delayed thrombosis. And this patient then ended up in something known as chronic vascular ischemia of the lower limb. And their gait may not be same. The vascular ischemic pain is so high that they may not get a same recovery as the other multi-ligament patients are. So I think timely study with 10 minutes investigation will not harm them.
And Dr. Vivek, your comment?
Yeah, I think I would take the middle path. I think what Raju was trying to say is foremost important is the serial examination of pulse. Whether it is the time 0, day 1 or day 3. If the pulse is impeccable, it's a robust pulse.
Sir, sorry to interrupt you. It's a private practice. Patients comes to you in our OPD 5 days after 3 to 5 days, and you want to perform a surgery. There is no issue of serial.
I'm coming to that, Raju. I'm coming to that. So, I'm also in a private practice only. See, this is an institution. It's a private institution, and all of us are responsible for the limbs. Yes. So whether it's the 3rd day, 5th day, 7th day does not make a difference. If my patient has got a robust pulse, all of us being a MBBS graduates and an orthopedic surgeon know what's a robust pulse. If it's a robust pulse, I would not do. Let me put it very clearly. But if I have slightest of the doubt, the limb looks slightly different, there is a bit of cold thing. Yes, the pulse is okay, but it appears a bit cold. The dislocation was quite severe. I would not hesitate either. So that's where I want to bring the, Roshan's comment that don't be in doubt. If you have a doubt, just do it. 10 minutes investigation will certainly save it. But a clinical examination of a robust pulse with the limb which is warm, you have got a fantastic capillary filling, or there is no sign of any ischemia, whether chronic or acute or whatever, then I would not do it just like that.
Okay, fine. One more question from your lecture: external splint test for 4 weeks. Dr. Raju, you don't allow any range of motion before that?
No, if I put the patient on a brace, especially for multi-ligaments, my preferred brace was a dynamic brace. I would allow them immediate range of motion, at least from 0 to 90.
Okay, fine. You don't splint them in an extension, and you just allow movement.
I allow immediate range of motion. Yes.
Okay, Dr. Deepak Joshi, do you follow same?
Yeah, exactly the way that Raju does. Definitely, this is how we follow. Acute injuries generally come less to us. Again, the patients come late to us. But definitely, if the patients come acute, this is how we see. The other thing is the ankle brachial pressure index. So that is quite useful in early injuries, where we can, if we have a doubt in that, definitely we can go for the angio, MR angio.
Can I ask something, Raju and all panelists except Deepak Joshi? How many of us have actually measured ankle brachial pressure index in last 15 years?
I have only seen it once, and I found it very cumbersome. And I
never use it.
Yeah, so I don't know. I mean, we would love to hear from Deepak more, but it's said it's quite useful, but I have never measured it.
So it is not. In fact, recent studies have found that it is unreliable in diabetics and hypertensives, in elderly patients, and cutoff is also controversial. So it is not recommended by the multi-ligament study group.
One more question regarding.
I think
Deepak, do you routinely measure it in all patients?
Or patients come with an acute injuries. Definitely, this is how our residents are trained, so they routinely measure it. So it's part of our treatment protocol. That's how we do it. The patients come very acute, but as I said, that most of the time patients come after maybe a month, 2 months, something like that. So there it is not done, but definitely in acute injuries, that's how we started doing it, and we are still doing it.
Any question, Dr. Rajiv? You want to comment?
Yeah, Raju. So what is your weight bearing protocol for this multi-ligament injury?
Non-weight bearing for 6 weeks. Period. I mean, I put them on this brace and non-weight bearing for 6 weeks.
My question to all faculty regarding this peroneus graft: how frequently you are using in your multi-ligament injuries? Start from Dr. Rajiv Raman.
Yeah, for multi-ligament injury, I definitely it's my favorite, one of the favorite grafts, except for in athletic population I avoid it because it's one of the important tendon for toe off of the gait cycle. So in athletic population, usually I prefer to take graft from the other limb rather than taking a peroneus from the ipsilateral limb. But here, in all other cases, I prefer the peroneus. It's a very good graft, especially for PCL when you need a long and robust graft. By peroneus gives you a thicker graft and a longer graft.
Dr. Pratmesh?
Yes, around 10% of my grafts are peroneus, approx.
Okay, fine. Dr. Roshan?
Yeah, so if I had to do a multi-ligament reconstruction when I'm doing the ACL, PCL and collateral ligaments, peroneus longus is my standby choice. Usually I do the same side hamstring, then I take the opposite side hamstring, and if required, I'll do the quadriceps from the same side, and then I can get a better graft. If it is 3 grafts, still I can manage. If I require 4 grafts, then I will take a peroneus longus.
So your preference is last one, peroneus.
Yes.
Okay, Dr. Jaya?
Yeah, I won't take peroneus. I use the quadriceps, hamstring, and patellar tendon.
Sridhar?
Routinely, I don't take. For multi-ligamentous, if there is any shortage, first preference is hamstring, then patellar. Last option is peroneus.
Okay, fine. Pankaj?
I would agree that I use peroneus only in very few selected patients of mine. Now, having said that, acute multi-ligament where all the ligaments need reconstruction is not very common in my practice. But for the larger benefit of the audience, Dr. Raju, please allow me to ask a very basic question. as in how do you prevent tunnel coalescence in a patient where you are doing an ACL along with PLC on the femoral side?
Right. So in that case, for the ACL, I would prefer to use an outside-in jig where I can control the trajectory rather than an inside-out method. And there are published guide wire trajectories, but then you have to rely on the on-the-spot decision. So if I feel that on the lateral side, the femoral tunnels have a chance to coalesce, I will first put in all the guide wires. It is recommended to first put the guide wires and only then drain the tunnels. And I use the outside-in technique quite liberally in such cases. You can then place the tunnel in whichever direction that you want.
Lovely. Thank you.
I think if we keep our wire direction on the proximal and superior, I think it doesn't coalesce with whether you are doing ACL and PCL. It is same with the MCL.
I think the issue is more critical of coalescence is on medial side rather than lateral side.
I agree.
The lateral side, if you see the attachment of the lateral collateral ligament as well as the popliteal, they are more anterior onto the femoral condyle, very close to the articular cartilage. In fact, popliteus is very close to the articular cartilage, and later on you can see the attachment of the lateral collateral ligament. Whereas the ACL, the coming out of your guide pin is very low onto the femoral condyle. So I think the tunnel convergence, the issue is more on the medial side when you're doing PCL with PMC. If you're doing a Lapra type of reconstruction on medial side, where you want to reconstruct the medial collateral ligament and POL ligament, in those situations, there could be very high chances of tunnel coalescence on the medial side.
Okay, Dr. Raju, you can just show us your case in a fast mode.
Okay. So this is the first case. This person is a weightlifter. He was trying to squat, I think, 150 kilos, and he lost control and he fell. He has injured both the knees. So on his left side, he has, as you can see from the ecchymosis pattern, a PCL injury. None of this obviously was reported in the MRI. This is an acute injury scenario. The MRI just reported the most obvious injury. He has a patellar tendon rupture. He has a PCL injury in addition, and he also has an ACL injury. And on the other side, he has a quadriceps tendon rupture. So this is the injury pattern of this particular gentleman. And the patellar tendon rupture is of a fairly severe end, fairly severe type. Half of the patellar tendon has gone from the patella, half of it has gone from the tibial tuberosity. Due to shortage of time, I'll just quickly rush through what I managed to do for this particular patient. So I used the hamstrings and reconstructed the patellar tendon as per the published paper by my good friend Sundar Rajan, the figure of 8 technique, and did a standard repair of the retinaculum as can be seen. He also had a ACL injury, which was a Sherman type 1. It was nearly gone fully from the stump. So a primary ACL repair was done using a standard shoulder suture anchor. And on the other side, the quadriceps tendon was repaired using a transosseous technique. So initially, the most superficial limb of the quadriceps, the rectus, seemed more or less intact. But on reflecting that, there was a full thickness tear of the underlying quadriceps mechanism. It is important in such instances to remember that these people are often on steroids, and that makes their tendons very weak. So a quadriceps repair was done. So this was him at quadriceps tendon repaired, and one by one SLR lift करके दिखाना please. पहले So this is the dynamic PCL brace that I was referring to. So in this particular instance, I chose to treat the PCL conservatively, non-operatively, and on the other side, the quadriceps tendon repair has been done in a standard manner. Ready? And eventually, in 7 to 8 months' time, this gentleman is back to doing what he enjoys. He is a popular bodybuilder in Delhi. So the learning points from this case was that when there is too much injury, both the limbs injured, quadriceps tendon on one side, patellar tendon on one side, PCL, ACL, sometimes less is more. Try to repair whatever you can and try to see whatever you can treat conservatively. And I also learned that gravity is the biggest enemy of the PCL injured or the PCL reconstructed knee. And sometimes a dynamic brace can go to the extent of allowing this ligament to heal optimally with minimum residual instability. I do agree a better way of treating him would have been maybe simultaneously reconstructing the PCL, but he's back to doing what he enjoys. And I had planned a staged PCL reconstruction for him. And I would welcome comments and critiques on this particular case.
Raju sir, my comment, if putting a pad under the calf when you don't have PCL braces with a short knee, with a long knee brace,
it's not very reliable. That is the only problem. So you can put that pad, you can have a static PCL brace as well. Of course, the dynamic PCL brace is very expensive. The static PCL brace works nearly as well, but just putting in a pad, it doesn't work. The patients find it very uncomfortable. The pad keeps on decreasing in height and eventually gravity wins and the PCL stretches out.
Okay, fine. Pankaj, now we are short of time.
Yeah. Thank you, Dr. Raju. And now I invite Dr. Roshan, who has some pressing reason to leave us early. So may I request him to start with his presentation?
He's a birthday boy. That's why he wanted
birthday boy today. I have to celebrate his birthday also.
Oh yeah, happy birthday, Dr. Roshan. Sorry, I joined late. I didn't know that. But please, Dr. Roshan Vadai, please start your case. Thank you.
I don't have a case. Basically, I'm going to quickly run through the management protocols for chondral, osteochondral. And in the same presentation, I'm going to demonstrate 2 or 3 cases what has been done. So the cartilage has been, it's a marvelous structure, tough, elastic and durable. And if normal, it will last lifetime. But if abnormal, it will give you severe pain. So normal articular cartilage, if you see in this video, it's a very shiny, it's a glossy structure, which has got almost depth of the 2 to 2.5 millimeter on the femoral condyle weight bearing area. And if it is associated with even a small flat tear, it will lead to severe pain. So such cases will lead to severe pain, and you have to be very careful when you are treating this kind of pain. Why is it not moving? My presentation is not moving. Hello? Hello? Can you hear me?
Yes, we can hear you.
Okay. So from Hunter's age, that is 1743, the Hippocrates has said that articular cartilage injuries are being shown to progress to early arthritis, and the early regenerative technique should be the only way to treat this kind of lesions. And the causes could be anything, starts from sports trauma to the pathological diseases like osteochondritis dissecans. There has been classification, which is outer beach classification, which we are using clinical in our clinical practice since more than 30 years now. Or there could be MRI or radiological classification or arthroscopic classification, which has been popularized recently. Imaging is a mainstay in management of cartilage disease, especially the sequential MRI with delayed gadolinium enhanced, or cartilogram, which has been described as a cartilage sequence joint, which is a complete cartilage management. So what are the options currently available? It could be a benign neglect, as been described by many literature, where we have a defect less than 1 centimeter square, or it could be debridement, reduced perforation, abrasion, arthroplasty, Moseley's osteochondral mixture, Stidman's microfracture, periosteal grafting, which was practiced in before, and osteochondral allograft or osteochondral autograft like BioUni, or it could be biomaterials like BMAC and others. So let's understand. Hello, can you hear me now?
Your sound is not, you're low.
Sound is very low, Roshan.
Hello.
Yeah. Hello.
Hello, can you hear me?
Yes, we can hear you, but your sound is low. You just increase your audio volume.
It's full.
Okay, go ahead then.
So what are the possibilities of treatment algorithm which we just went through? Non-surgical management is this, other newer modalities of pain management can be used, or simple hyaluronic acid, which has been used in clinical practice. But these are the not treatment for your surgical management for cartilage. So over a period, we have moved from debridement to lavage to from reparative technique to restorative technique. And it has been a very, very important landmark in our clinical practice where we can see all these reparative techniques in the cartilage disease management. I don't know why my internet is slow.
No, now it's okay. Sir, you go ahead.
But my slides are not moving here.
Your internet is slow.
So knee, as a Brian Cole has described the cartilage, ligament instability, mechanical malalignment, and the functional meniscal tear as an organ of the knee joint. And this knee joint, if in toto is intact, then only it can lead to a very good stability around the knee joint. If it is associated with any comorbidities, then it needs to be corrected so as to get a better reparative results of the knee joint. So what are the treatment goals? The permanent restoration of cartilage, hyaline-like cartilage, and restoration of the cartilage. If not possible, at least a poor biomechanical properties of this fibrocartilage can give you of the pain, and this tends to wear off. So fibrocartilage may not substitute your hyaline-like cartilage, and one has to have very high demand athlete, especially in high demand athlete. You have to have very good hyaline-like cartilage for the management. So benign neglect has been described in our clinical practice, which may not lead to a fibrocartilage and it may not withstand lifestyle. This is a very famous study by Mosley where he divided three group of patients where he had done debridement only for the degenerative osteoarthrosis, and they found out there is no result between the cohort study of comparative study of debridement versus non-surgical management of the lavage treatment. So the natural history of this disease is again a fibrocartilage and temporary results. So most importantly, we have to study the osteochondritis dissecans. These are the pathology which are involving younger people or in younger population, which can lead to early arthritis of the both knee joints. So there could be associated with cartilage damage and associated meniscal lesion, which can make your life more, the patient's pain more miserable. So one such case where you can see the defect on the weight-bearing joint, that is on the femoral condyle, and a very big defect as compared to what has been practiced, what we usually tend to do a micro fracture. For such defects, you have to have some kind of management which will lead to a cartilage regeneration on that defect. So Jansen's abrasionplasty, arthroplasty was described as the abrasion of superficial subchondral bone, which can lead to fibrocartilage. Again, the life of the fibrocartilage is not so extensive, usually, and it leads to early arthritis. Then came the era of laser surgery in vogue of market pressure. People started using laser, YAG laser on the knee joint, and they found out that it works in early degenerative arthrosis. But it may not be a treatment for a focal degenerative lesion, especially in a younger population. Predis perforation was being tried with multiple drilling in subchondral bone. It was the first systematic approach towards the mesenchymal stem cell release inside the defect, and the result was fibrocartilage. Again, it never had a normal hyaline-like cartilage, but it was effective in certain patients. Steedman popularized technique known as microfracture, where he has studied almost 81 patients, and they found out that at 11 years, they have a very good compliance on those patients, especially lesion less than 4 centimeters square. So if these lesions can be managed with microfracture, you can get a fibrocartilage which can last up to 10 years in your clinical practice. So this is how one can do microfracture techniques, and you have to do it with the depth of 2 to 4 millimeter so as to penetrate the subchondral bone, and the distance between two should be at least 3 to 4 holes in a centimeter square. So this microfracture will lead to blood flow inside the femoral canal, inside the defect of the cartilage, and which can fill up with the mesenchymal type of stem cells, which will regenerate the articular cartilage with the help of the pluripotent stem cells in the marrow. Osteochondral allograft was tried by Bugby and Alan Gross from Canada, and they found out that they have got very less results as far as allografts are concerned, especially in 200 cases where they use allograft, and it may not last longer, especially more than 15-20 years of condition. So it may not work as the natural hyaline-like cartilage. So Hangodi's mosaicplasty was popularized as cylindrical osteochondral autograft, which can be used from non-weight bearing area and can be transferred to the weight bearing area, and which can give rise to a fantastic result. The absolute contraindication is patient more than 50, especially depth more than 10 millimeter, and those patients may require the autografting before you do Hangodi's mosaicplasty. So again, the Hangodi published his data in 831 cases, and they found out 12 to 13 years good result, especially with 79% patient had an excellent result with less than 3% donor morbidity in his studies for Hangodi's mosaicplasty. The hyaline-like cartilage was found in certain cases, but the medium-term to long-term results may not be good, especially in younger population, which requires. Then came the era of uni-compartmental knee replacement, which has been used whenever you have a bigger defect, a defect more than 4 centimeters square, which are the worrisome when you may not get a better outcome. In such cases, you can do a bio-uni, that is, you can take the structural allograft from the donor an allograft and put it on the donor side, a surgical side. Like what you can see, there is a zig which is available, and through zig you can create a slot, and then you can fix it with the help of the press fit technique of unigrafting. Then came era of autologous counterside implantation. I still remember in 2010 we had a first case which was performed in India, and eventually we found out that it has got very good result, especially in defect less than 4 centimeters square. But it's a very expensive technique. It requires 2 surgical procedure, bone grafting, grafting of these marrow cells, and then reculturing into the cartilage cells and reculturing into the lab, and again reimplantation into the defect. So the short-term results are very good with this technique, and they found out that even the long-term results could be good. So there are 2 methods which are commonly used. One was a scaffold-based technique and gel-based technique. I had an experience of getting involved in both the technique, early regeneration of this cartilage, and which has been studied in the clinical practice. So this is one example, 22-year-old male who had a focal cartilage defect on the femoral condyle. In fact, the whole femoral condyle is flattened up, and you can see here, in such case, we have put the structural graft. This is the iliac race graft, which we took out triangular piece and we tried to fix it with the Herbert screw, and over which we have put the ACI graft. A similar way you can do it with the scaffold-based technique. As you can see here, this is indigenously developed scaffold in my institute. This is called PLA PCL scaffold. We cultured it, and this PCL scaffold is a matrix scaffold which can be covered with the chondrocyte, cultured chondrocyte, 50 million cells on both sides. So you can use either side, and with the defect you can really reimplant it, or you can suture it back, eventually you can see a better healing with the microfracture and the scaffold-based graft fitting onto the cartilage defect. So this is how the PLA PCL scaffold look like, and this is how we implant the PLA scaffold. You can see here. Eventually, you have to fix it with the help of fibrin glue and the articular cartilage. It stays back, and this is how it will stick back. So gel-based therapy can be used for the cartilage defect. As you can see here, the structural defect on the articular cartilage, and is completely fixed with the ACI, a gel-based ACI, which has been hardened, and now we can get a better range of motion. Is there any literature to prove that it works, the autologous counterside implantation? Yes, there are randomized trials which were being published, and they found out that this autologous counterside implantation, as far as the management of osteochondral defects is concerned. There are other techniques which has been used. I have never used in our clinical practice, like Morcellet's autogenous osteochondral mixture, which has been used by Raymond Kogart group, and the osteochondral autogenous transfer, which again we have not done it because we have a bio-uni system which has been popularized by Arthrex, and we commonly use it in our clinical practice. Spontaneous osteonecrosis of the femoral condyle is again a problem. You can see here the bigger defect, the bigger size, and necrosis around the femoral condyle, which can lead to early collapse. In such cases, you can do debridement. Sorry for voice. You can do a debridement, and then you can create a microfracture graft. You can see here the graft which has been placed on the defect, and eventually you can place your scaffold. In this case, we have done a scaffold, and you can repair this scaffold with the help of sutures, so that you can get a better fixation of the scaffold onto the this thing. So this is the result. At the end of 6 years, this patient had a full range of motion with a scar on the medial side and with healthy cartilage on the knee joint. The future is stem cell therapy. I really don't know whether it's going to work or it's not going to work. We are closely working with IIT Mumbai as well as the Mumbai Veterinary College for developing mesenchymal stem cells, especially the autologous derived stem cells, which can be used in cartilage therapy. I started doing the mesenchymal stem cell technique with Satori technique, where we started doing the liposuction of the abdomen so as to get a wonderful mesenchymal stem cells. This is a pluripotent stem cell which are rich in the fibrous tissue or the fat pad in anterior abdominal wall, and you can get it a very good amount of stem cells which can be reimplanted onto the knee joint, so as to get a wonderful cartilage which is very healthy, high line like cartilage, and you can get a very good layer. You can see these stem cells are very sticky tissues. You know, they eventually they stick together. This is a like glue-like sticky tissue, and they can stay back for quite longer time so as to regenerate the articular cartilage, as you can see in this demonstration here. The biomaterials hyaluron and bioscaffolds are commonly used in the experimental animals, and they have been shown to have some experimental value. But we don't have any solid concrete answer on it, and it's really futuristic to work on it. 3D printing of cell is commonly used in certain institutes in Korea and Japan, where they do 3D printing. This is one from Dr. Cho from Korea, and he has done a 3D printing of these cells where they regenerated a cell tissue, and they created a certain blocks of this cell tissue, like you can see here. This is Wang and Cho model where they recreated a cells so that the articular cartilage can regenerate on the top of it with the help of a hyaluronic acid as well as the implantation. So certain techniques are going to work in future, and I am very sure this is going to work. So what is the current protocol and algorithm? That is grade 1 injuries, conservative line of management, grade 2 debridement, and extensive control rehabilitation, as we have studied in other cases. Grade 3 and 4, especially up to 3 centimeters square or 4 centimeters square, I think you can easily consider ACI or the mosaic plastic. Beyond that, is better to do bio-uni and some other kind of procedure. Thank you.
Pankaj, you want to ask?
Yeah. I think it was a very extensive description of all the possible cartilage reconstruction techniques. And I would say thank you very much, Dr. Roshan, and wish you a very happy birthday. Is there any question coming from any other faculty member or any other person on the panel?
Yeah, Roshan, one question. So for song type of lesion, usually we were doing the multiple drilling technique. So do you prefer multiple drilling for song lesion of the isolated femoral condyle?
You know, spontaneous osteonecrosis of the femoral condyle is the one which is very difficult to treat, and eventually there is osteonecrosis of the subchondral bone, eventually making defect more than 8, 9, 10 millimeter depth. So such patients are very difficult to treat with only microfracture. In those cases, what we started doing now is taking the pre-iliac raise graft. In fact, we have done at least 7 cases now. In that we have taken an iliac raise graft and fixed it with the help of multiple. Initially, we used the Herbert screw. Now I started using biopins. There are certain biopins which are available. You can use 2 or 3 in case you want. You can cut the biopins and reuse it, and those biopins will fix your graft, and over which you can do, you know, maybe a PRP, BMAC, or some kind of procedures. So you have some scaffold to hold on, because remember the femoral condyle is a round structure. So you have to recreate that round anatomies for your cartilage to grow on it. So unless you have a round structure to regrow the cartilage to grow on it, it's not going to work. In fact, we are working on it with the Mumbai Veterinary College, where I am going and studying with horses as well as the few of the pigs. where we have done the surgeries on these pigs. And maybe next time when we have the session, we can show it.
Sir Roshan sir, sorry to interrupt you. My question to faculty is, what about the patellar defects? How you treat them? You showed us the bone marrow. You are putting stem cell. It was in supine or it is in prone position? Because arthroscopic picture was showing us it is supine in position.
Yes. So whenever I have to do a cartilage repair, I have learned one thing, that never do arthroscopy, always do open. So I think that surgeon's ego that I am an arthroscopy surgeon and I will do only arthroscopic repair is a myth in cartilage repair. Cartilage repair is the salvage procedure. The failure of cartilage surgery will lead to early arthritis. So I don't want to play with that. My skills are good enough to do arthroscopic repair of patella, but I think if you do open repair, a thorough debridement, and over which you can completely patch up your undersurface of patella with the help of either maybe the scaffold, so that you have to maintain the good amount of cartilage. So for me, cartilage repair on the femoral condyle, on undersurface of patella, a talus is always an open procedure, never an arthroscopic.
Is there any role of mosaicplasty in patellar articular cartilage defect?
Mosaicplasty
on the patellar side. Dr. Vivek, any comment on this?
I think some people have tried. If you ask, I think only Deepak Goel, I have spoken to him a couple of times. Deepak Goel has done few, but yes, it is not an easy job. I think initially, as Roshan said, most of the cases would respond to debridement. Otherwise, you have to do open procedure, and the deeper defect would do very well with even the ACI. Contrary to what it is said that femur followed by patella, they do well for ACI. But mosaicplasty is described to patella also.
The only risk is patella fracture, because you have very small patella and thin patella in India.
Yeah. So they have a thin plugs. In a male and all you can try, but women, yes, they have very thin patella and could be quite risky.
Okay. And any just comment to question to all the faculties is still microfracture is there or not? Do you do in your practice?
Yes.
Yeah, you do. Okay.
Microfracture is the bread and butter of arthroscopy surgeon. So they have to learn microfracture.
I think it is the cheapest mode of cartilage.
It is the most important and most clinically used and validated technique to repair the articular cartilage is a microfracture.
But in literature, we don't see nowadays, because it gives you fibrous cartilage. It is not long lasting. But in practice, we do.
Roshan, there is one question from Dr. Fahad. I think he has not understood. See, you have probably he has not understood that he has written when you use the iliac crest graft, how you restore the cartilage. So I think you have to emphasize that, over and above you use something else.
Yes. So after putting iliac crest graft, over which we put a scaffold, either in the form of a gel-based management, either a BMAC or a scaffold-based articular cartilage management. So there are three techniques which we commonly use in our institute: the bone marrow aspirate concentrate, the gel base, as well as the scaffold base, which is our own.
Okay, thank you, Dr. Roshan.
Many happiness of the Roshan.
Yeah, thank you very much.
Dr. Jaya, you want to comment?
Continuing watching.
No.
But I
wishing it.
Mute on it. Yes.
Okay. Lovely. Thank you so much. Now I invite.
Thank you, Dr. Roshan.
Thank you.
Now I invite Dr. Rajiv Raman to tell us about meniscal repair in multiple situations of meniscal tears.
Thank you, Rajiv, for inviting. I think Rajiv told me it's a case-based discussion. So just
It was a case-based discussion.
Yeah. So I have not. I will make it case-based discussion also and involve one or two faculty. So this is one of the case ACL with partial thickness meniscal tear, and if you can see, most of the ACL when you are dealing with this ACL tear patients and you probe the meniscus, you can see sometimes you may get a undersurface or a superior surface partial tear thickness meniscal tear. So Vivek, how do you deal with such type of patient? Partial thickness meniscal tear with ACL injury.
You want to say the partial thickness, mostly under surface?
Yes.
So Raju, they are actually known as instability tears. Okay, they are very minimal, so they will be usually, let's say, less than, most of the time I have observed them on the lateral meniscus. They are in the posterior third and they are on the under surface, and they are usually less than 50% of the entire substance. So if that is the case, then I just don't do anything. Probe, leave it, stabilize the the ACL, and I keep them non-weight bedding for a month and ask them to avoid squatting anyway, that we ask in all ACL patients. But if it is almost inching to the let's say the superior surface, it's like your probe can almost come out, then in some cases, if it is large enough, like long enough, then maybe one inside, all inside, that's all. Otherwise 99.9% nothing.
So I think very good message from Dr. Vivek Pandey. So you probe it and see whether your probe is coming. You can see it's less than 50%, 5 millimeter probe. It's not going completely in. So such type of meniscus tear, you can leave it alone also. You can probe it, pull it also, see whether it's a unstable tear or a stable tear. And either you can leave it alone or just debride the undersurface, because it's a very vascular structure. Literature has shown, and there is enough evidence in literature, when you treat this such type of tear conservatively, once you reconstruct your ACL, there is no pivoting of the knee, and this tear will not progress anymore once your ACL has been reconstructed. So either you leave it alone or just go for a partial debridement. So Rajiv, would you differ from this?
I agree with this Dr. Vivek Pandey comment, and same observation is with me, because if you are doing ACL reconstruction, all the bone marrow comes in this vicinity and get healed. I think we should leave it if it is stable.
So I think second case, there is a root avulsion of posterior horn of the lateral meniscus. This is a small video here, and not a very uncommon scenario, but in this patient, you can see there is a avulsion of the whole of the root from the posterior horn of the lateral meniscus. So Jaya, how do you proceed with such type of cases?
I do root repair in this patient. I will probe it and see that how much is the root is available, it is retracted, posterior capsule, chronic, and these things I will see and then do the root repair.
So if you can see here, it was not only a root repair, there was some amount of cartilage defect also there. If you can see, just when I put my scope inside, you can see the cartilage defect here. So a big cartilage defect was there. It was a loose body. So I have removed this loose body. And Vivek, how will you treat this cartilage defect? Suppose you will just repair the root, leave it like that for healing, or you will do something for this cartilage defect?
Rajiv, can you just a bit explain the mechanism of injury? Is it purely an ACL tear, or there was some kind of a medial side injury also?
Yeah, the patient has a ACL tear. He has a grade 2 MCL tear, and it was big. It was an RTA accident, and it was an acute injury. Almost 10 days after injury, we got this patient, and on 11th day, we put our scope inside. So you can see the margins, the root margins are quite red. You can see the margins of the articular surface also. It's a fresh injury almost.
Okay, so fair enough. That's what, see these, this posterolateral cartilage defects, okay, they are seen in two situations. One in a very explosive injury where actually it is like a pivoting, that whole part of the cartilage shears off. One is possible is this. Second is it's a serious valgus type of injury where when the lateral femoral condyle presses upon the, the lateral tibial plateau, it can actually crush the meniscus and bisect into two. So you may find a root tear, what Jaya was trying to say, or sometimes it's actually a radial tear at the level of the posterior third and root level. Okay. Now I would treat it the root tear bar the radial tear on the standard lines. But if the fragment is quite big, Raju, okay, let's say it's more than 1 centimeter, 1.5 centimeter, and I feel it is fixable, then what I have done in one case, I actually have opened it posteriorly. I've opened it posteriorly with about 2-inch incision. I have gone and I have fixed the whole fragment with almost like with one this Hubbard screw, and they heat it very well. And rest it goes on the standard principle. But if it is less than 0.5 centimeter, 1 centimeter, maybe 3-4 weeks, then I don't bother. Then I just remove and wait and watch.
Raju, any difference in opinion?
I would probably go and do the same.
So it was a small defect, almost 1 to 1.5 centimeter. You can see here. So we went for a root repair, standard root repair technique with the ACL jig, and you can see here the posterior tunnel was made, and with the suture passing device, and no, this is another case. Sorry. So you can see, and once you have fixed it, you can see, and once the root was fixed, you can see the whole of the cartilage got covered under the meniscus. So I didn't do anything for this cartilage defect and leave it alone. And after 3 months, the patient is doing well. So Roshan is there. He has went for his birthday party.
No, I think he left.
No,
yeah, he
yes,
left.
yes, I'm listening.
All right. Yeah. Pratimesh, so what do you will do in such type of case?
I can listen to you.
Oh, Roshan, you are in Karate. Yeah. So you have seen this case,
yes,
Roshan?
Yes, I'm seeing. I'm watching your video.
Yeah. So you have given a very good lecture on cartilage repair. So what will be your take on such type of cases? So under surface cartilage.
Yes, nothing to do on the stage.
Yeah. So I think Vivek has a very good point. If it is a big fragment, you can go posterolaterally, open it, fix it. But a smaller fragment, if it is well covered by the meniscus tissue, just leave it alone. Keep this patient non-weight bearing for 6 to 8 weeks, and most of the time heals very well. And you will get a good range of motion also in such type of patient. This is another case.
Actually, Raju, sometimes if you can place that fragment well back in the place, and kind of just hammer with the probe, it tends to settle there. It doesn't move. I have done it in one case. It didn't move actually. It healed it there because it has got something like fracture spikes. But that was only one case. So I have seen like this about 4 cases till date, not many.
Very rare injury. So that was the first type of injury. I thought what to do, whether I should counsel the patient. So later on, surgery literature also, if it's a small defect, leave it alone. Most of this posterolateral cartilage defect heals very well. So this is another case. After trimming of the discoid meniscus, you can see the unstable rim of discoid is there. And most of the time now it's recommended that you should preserve this unstable rim of discoid. So Pratimesh, what is your say on such type of unstable outer rim of the discoid? So how do you preserve the unstable outer rim of discoid meniscus?
Usually I can use 1 or 2 of the all inside devices here.
So yes, you can use all inside device also, and the only thing is that using an all inside device, 3 or 4 all inside sutures usually costs very much. So this is a very cost effective technique. You can use the suture passer with the fiber wire, and just you can take a bite. Be careful so that you are not damaging the cartilage, and just.
Rajiv?
Yeah.
Rajiv?
Yes, Vivek, I can hear you.
Yeah, which device is this?
This is the suture passer device, Fast Fix Mini. All right, I will not explain. And you can use also this. You can use any. It's a Fast Fix Mini from Smith and Nephew. It's a very good device for all inside meniscus repair. So you can use it. Fast Fix Mini from Smith and Nephew.
It's a beautiful device. I would say
First pass mini, sir. First pass mini.
First pass mini, and it says self-retrieving. You can see once you.
I saw because I've been using this Scorpion and sometimes it fails.
So
this is a very good device, sir. Fast pass mini is a
device. So just you repair it. I think the video is not running, and by this you can take 4 or 5 vertical stitches with one ortho cord. You can just repair whole of the lateral limb, and that costs approximately 2,000 only for the patient. So this is a very good and cost-effective technique for stabilizing the lateral. The video is not running. I think some issue is there.
Raman, what is the size of your suture material?
It was ortho cord.
Size.
Yeah.
Is it 20?
No, it's 20. So the last case, 10-week old bucket handle tear. So Rajiv, what is your say about repairing this old bucket handle tear when you get it at 10 weeks or 12 weeks?
Doesn't matter to me if it is a 10 weeks, it is a 3 months, it is a 6 months. If it is a reducible, it is coming nicely and the tissue is good. I always try to preserve the meniscus, irrespective of duration.
Raju, you would say on timing, or what are the criteria you prefer for repairing this bucket?
No time limit for me. It is the quality of tissue. It is reducible well. It is staying at this place. I always try to repair it.
Vivek, any point on this?
Yeah, I think I concur with Rajiv. You know that if it is repairable, reducible, repairable, the location. Most important, it should be reducible first, you know, because sometimes they're very old now. They would have healed in a new position, absolutely, you know, convoluted 360, sometime, you know, almost double. Then it is very difficult. Then you take it off, but preserve it as far as possible.
Dr. Raju Ishwaran, your say on?
I would agree with the previously made points. It should be, the tear should be presentable. It should not be very rounded, and it should not be old looking. And if it is easily reducible, even after, let's say, doing an MCL micro perforation, even if it reduces after that and stays put, I will go ahead and repair it.
So good thing is that it's a issue.
Raju, there is another saying that even if you repair, and sometimes what I made, a part would not heal. So even then you end up with a lesser meniscectomy what you would have done on day one.
Yes. So there are very two good messages from Dr. Vivek and Dr. Raju. First, see the quality of the tissue, see the rounding. Well, if your medial border, if your inner border is rounded up, so those tissues are not good tissues for repair. And yes, timing is not a big issue. You can repair this up to 12 weeks, 14 weeks. But I think beyond 14, 16 weeks, it's very difficult to repair those meniscus because you get rounding of the meniscus. It's almost irreducible. It has thickened down, and the margins have become quite avascular. So it's very difficult to repair after 14 or 16 weeks. Results are quite not good. So such type of bucket handle standard technique is reduce the width of probe, and you can just repair with your all inside technique or inside out or outside in technique. The first and most important point in such type of meniscus repair is that see the quality of the tissue, see the demand of the knee, and see the age of the patient. If it fulfills all the three criteria, go for a meniscus saving procedure, because we know that if you remove this meniscus, there will be increased joint reaction force, and ultimately those knee will go into arthritic changes quite early. Especially the one message should be very clear: try to repair most of this lateral meniscus, because the joint reaction force after lateral meniscectomy is higher when it if you compare it with the medial meniscectomy. So lateral meniscectomy, more meniscus most of the time, always try to preserve it. I think one case is more, one more case is there, but the video is not running. The issue is the video is not running.
Meanwhile, a few questions to Dr. Rajiv.
Yes.
Just related to comment from Dr. Vivek, if you have a complete radial tear near the root, how you are going to manage this?
So yes,
you deal with like a root tear, or you are going to repair it?
So complete radial tear near the root, you can treat it. If it's a fresh injury, most of the time it's very mobile tear. So you can just repair it whenever it is coming without any tension. All right. So I don't prefer this crisscross technique, because I don't believe how much stability it gets, and there is a good stress riser over the crisscross suture also. So most of the time, complete root tear in the posterior horn, I repair it like a root repair only, not like a meniscus tear with a crisscross technique or something like that. I would like to have opinion of other faculty also on this.
I would do exactly the same. I would not hesitate to shorten the meniscus a bit and repair the remaining portion back.
As a root tear?
As a root tear, yes.
Okay, fine. Any difference in opinion among the faculties? I think everyone is going to treat like this. And one more question regarding the horizontal tears. They are very common. And the problem with this horizontal tears, if you just do the partial meniscectomy, still it comes in MRI, it is a tear. Is there any way of repairing, suturing like a rope? Dr. Prathamesh, any comment on this? How you deal with horizontal tears?
Please see the repairability aspect. If it is repairable, I will definitely do a repair. My preferred devices are now all suture or an air kind of a device as compared to a fast fix. But yes, try to repair as much as possible.
Dr. Vivek, do you believe in that rope technique of repairing horizontal tears to close the upper flap and lower flap, superior inferior flaps?
I've done in few, Raju. I would admit that I don't do it very often, but because most of these horizontal tears, you do get in the, relatively 50 plus, you end up you are doing arthroscopy for something. And so if I can repair, as Pratmesh said, you can close the mouth, it's okay. If it looks okay, you curate the substance and try to close it with this technique. Otherwise, sometimes I leave it.
You leave it. Okay, fine. Any comment from other faculty members?
So horizontal tear always try to probe the upper and lower limb. If something is coming inside, I think those unstable layer, you can debride it. And you can take this all inside device and you can put some vertical matter suture also. And usually by that, whole of the horizontal tear, whole of the rib becomes quite stable.
So what I do is I probe the both flaps. Whichever flap is very much unstable, I debride. And if it is stable, both are stable, I make a vertical repair with the fast mini.
Yes.
So the entire thing, and I will debride between the flaps, and that's how the healing capacity will increase.
I think the message is we should try to preserve the meniscus. And as already Dr. Vivek commented on that, if you repair it fails, still you do partial meniscectomy with less tissue, still you have good preservation of your meniscal tissue. I think we can invite our next speaker, Pankaj.
Yes, Dr. Vivek Pandey, we are eagerly waiting for your presentation.
Thank you, Raju. Just give me a moment.
One more question while you are uploading, Dr. Rajiv, how you do mid-part repairs? You do always all inside out or outside in? Is there any difference in your practice? Because inside and outside in is very cheaper in the
yes, definitely. Whenever there is a cost concern, go for an outside in technique. But if it's not a cost concern, all inside is I think gold standard for me always. But whenever the cost constraint is there, I prefer outside in technique.
Is there any biomechanical difference if you do outside in or inside out? Does it really matters? Inside out is better than outside in?
I don't think. I have done both the technique. Results are quite good, and I think both the technique works well.
One more last comment on you. If you had big, long, old bucket handle tear, do believe in the fibrin glue therapy procedures, or if you have isolated meniscal tears, how do you enhance your healing of?
I have not done it yet, but some people are doing it with good results, have shown good results. But I have not done it yet. Fibrin glue or fallout, putting it in between the repair. I have not done it.
I use in my isolated meniscal repairs. I always use. Any comment from other faculty members?
On fibrin glue.
Fibrin clot. Sorry, fibrin clot.
Fibrin clot, I think.
Dr. Vivek, are you ready?
Yes.
Yeah, you can go ahead.
Okay. Good evening, Rajiv. Thank you so much. I think I'm attending a webinar like this after a long time, because in between I was almost off. I think it was too much of a pandemic of webinar also. So good to be back, and we had some really good, thought-provoking questions and discussions today. So what I'm going to do, Raju, is I will start with a basic slide, then I'll put up a small case. Then I will tell that what did we do? Okay, that looking at that case, the perspective, what did we do? Then we'll go ahead with some principles, and I'll show some more videos regarding that, some tips and bits here and there. So ACL failure, it's yet to be continued to be defined, that what exactly is the ACL failure. It could be varying from recurrent patholaxity. It could be a stable knee, but otherwise a stiff and a very painful knee. The patients who have not been able to return to their activities of daily living, loss of range of motion, and so on and so forth. So the question comes, what leads to a poor outcome of ACL? One is straight away the structural failure, where there is a graft disruption. and there's a functional instability. And the most important reason, what we are actually also going to discuss today, is what leads to the ACL failure. The most common and most important reason is the technical error, followed by the diagnostic error. Means somewhere, we could not actually figure out and we left the lesion undiagnosed or untreated. Followed by, there are situations where you have done a good job, but the graft did not get incorporated, due to either the poor biology, and there are people who are smokers, there are people who are diabetics, or they went on to the too early rehabilitation where there was too much mobility at the tunnel site, or the fixation was not good. So something which led to the poor graft incorporation. Sometimes the rehabilitation could be wrongly started, too aggressive, and sometimes there is a re-trauma. Then there are other reasons which can lead to a failed ACL, that is infection, lost range of motion, the cyclops lesion, or the, let's say, the neurovascular injury, or the extensor mechanism dysfunction. If the ACL has failed within 3 months, it is usually because of the infection or loss of fixation, stiffness or cyclops. Between 3 to 12 months, that is within a year, it is usually the technical error, diagnostic error, wrong rehab, non-incorporated graft, or a trauma. And more than 12 months means if everything was fine, then what went wrong, then that is usually the trauma. Okay. So I'm going to show you a case history. We had a patient who was 32-year-old male who presented with recurrent instability in his left knee for 1 full year. He was operated for ACL reconstruction elsewhere about 18 months back. And following that, he did not give any history of trauma or any infection. And he said that I did undergo the routine rehabilitation program. When we examined this patient, we realized that he had a normal gait and a full range of motion, and he did not have any swelling or any markers of inflammation onto the skin or elsewhere. The Lachman and pivot shift were grade 3. The PLC and PMC were normal. That is, both the corners were completely normal. His blood investigations were absolutely normal, did not show any sign of any subtle infection, though it is very hard to believe that at 18 months somebody would have any lurking infection. His X-ray showed in normal alignment. Here you can see in near normal alignment, but without any evidence of arthritis. But what you can note here is that the tibial tunnel, we can't really comment, but the femoral tunnel, you can see that it is almost vertical. So it means whenever and wherever he was operated basically with the kind of a transtibial technique, which would have led to a vertical graft. When we did the CT, it showed a malpositioned femoral tunnel. So you see, this is the posterior aspect. The tunnel should have been somewhere here. This is the place where the tunnel should have been, but in fact, it is lined quite anterior. It's almost a vertical tunnel. And here, if you see, the tibial tunnel is reasonably in place. So it's almost like you can say 40% of the anteroposterior width. Okay, so this one seems to be okay, but the femoral tunnel is certainly wrong. When we measured the diameter, we found that it was 12 mm. So if you see the case history, bit by bit, we are trying to figure out that what went wrong. Means if I go back here, it says that I was trying to see the gait in which, what if there is a varus thrust? If there's a varus thrust, it means that there is a PLC weakness. The range of motion was full. There was no swelling, indicating that there was no arthrofibrosis. Probably there's no infection. PLC and PMC was normal. It means we were trying to rule out, was there any underlying collateral or the corner injury left which was not treated. CT, we did see the place of the tunnel and we saw the diameter of the tunnel, because the diameter of tunnel is going to decide whether I want to do the revision ACL in the same sitting or we want to do in the stage. So since he had no infection, he had no loss of range of motion, the tunnel was vertical. So we decided that we will go ahead with the revision ACLR in single stage, because the tunnel diameter was only 12 mm. So about 14 plus, let's say the tunnel diameters are 15 mm, then in those cases, it is extremely difficult to do the single stage. You have to always graft it. My choice of graft in revision is almost always BTB and peroneus longus, because both I have a very good control over the diameter. In BTB, I can take 10, and peroneus, all of us know, if you got 4-strand graft, actually sometimes can end up in 11 mm graft. That thick graft could be sometimes. As we have discussed in the last few sessions today, that the ALL reconstruction or ALL so-called modified Lemire procedure, IT-band tenodesis, could be one of the very good adjunct procedure in the patients in whom you are doing the revision ACL. So we planned for that also. And then we decided and we counseled the patient that we are going to go ahead with a very slow rehab. It will not be the accelerated rehab. We also told him that the prognosis remains guarded. We have to see at the end of 1 year that how do you do, and likelihood of you reaching the same level of these sports is always, should be seen with a caution. Not necessarily you will reach the same level. So coming to the, the main points. So whenever you are planning a revision, always evaluate your patient very well, both history-wise, examination-wise, and investigation-wise. Sit and plan. And I would always say that if you are in the beginning of your career, always discuss with some senior colleagues, because that will give you a lot of insight. Revision is not a joke. Even in the expert's hand, sometimes we are also in trouble. And try to, watch some videos, try to get some surgical tips and tricks from the colleagues who have done probably more than you. History-wise, always ask the symptoms. Try to figure out from the history sheet what graft was taken, what kind of fixation method was used, which will be always also seen on the X-ray. What kind of rehabilitation was done, where was the rehab done, was there any slightest history of infection? And I would add here 2 important points: smokers and diabetics. These are 2 enemies in orthopedics, remember. Okay, very, very undermined, not much we discuss about it. But smoking and diabetes, if they're around, I'm always very skeptical to touch them. When you examine, always look at the alignment. So look for if there's any varus alignment, any varus thrust, what is the range of motion, how is the extensor mechanism. Means often you will find that these patients may have, they would have gone 1 or 2 surgeries, they wouldn't have rehab well. Their quadriceps is very, very thin, very thin. So it is important that you build up their muscle bulk first, put them on extensive rehab program. Nothing they are going to lose if they do the extensive rehab for next two months and then come back, unless and until you are sitting in private and want, scared of losing the patient. The scars and the arthritis. Apart from the, the ACL, we know that it's unstable, but it is very important, very, very important that you do rule out these 2 areas of instability, that is PMC and the PLC. PMC is very hard to miss. It is often the PLC which is missed. And, the alignment. So alignment, I would always say, look at the alignment and look at these corners. So alignments and corner are the 2 important things which should not be missed. Then you always go ahead with the, the current disability and demand. You always ask your patient that what exactly are you looking for? The rule out any underlying infection. We move on to the imaging. So imaging is always plain X-ray, where you do the weight bearing AP lateral. 45-degree flexion, though discussed a lot, but I personally don't do it because I don't change my planning in that. In the imaging, you can look at the tunnel positions. Like in this, if you see, this is 2 anterior here and this is 2 vertical. So you straight away in the X-ray itself, that your femoral tunnel, which has been, done in the past, is wrong. Whereas the tibial tunnel is almost all right. It's almost at the 43% from the anterior end. Is there any evidence of arthritis? So we can see in this X-ray, there seems to be no arthritis, maybe very, very early, but this is okay. My plan will not change. But the second important thing which has come off late, there has been a lot of discussion in the last 10 years, is the tibial slope. There is a recent paper which is, I think, published by Dada also, Swanendu Samantha, in, I think, Journal of Orthopaedics in 2020, regarding the tibial slope. So if the tibial slope is more than 8 to 12 degree, because if you read various papers, they are varying from 8 degree to 12 degree. If it is high, then you might have to do a closing osteotomy to reduce this slope, because if the slope remains very high, that will, even if you do the revision ACL, the ACL can re-tear. MRI per se is not going to change my plan, but it will help me in understanding what's happening to the meniscus, what's happening to the cartilage. So if there is a root tear especially, or if there's a bucket handle tear, which is causing a big problem, or an unstable meniscus, especially the root tear, that we can plan to fix. But the key imaging, remember, in the revision ACL, if the juniors are watching, the key imaging is always the CT scan, where you can actually check the tunnel position and the tunnel dilation and the position possibly of the hardware, because it is the tunnel dilation which will let you know whether you want to do in one stage or whether you want to go ahead and do it in the 2 stage. So this is what is usually followed world over. So tunnel could be totally malposition, slightly malposition. It means here your actual tunnel should be here, but you are here, it's okay, then no problem. Here the actual tunnel should be here, but your tunnel which has been made by the previous surgeon is here, then it's an overlap. Tunnel is exactly where it is, that is ideal position, and tunnel is ideal, but here the dilation is more than 14 mm. So if it's a malposition tunnel, it's a very happy situation. I don't have to bother drill a new anatomic tunnel. If the tunnel is slightly malpositioned, then there are 2 things. You can try introp diverging the tunnel. So you start from the same point, but you go a little bit diverge. So in this case, what happens outside in drilling is very good. But if you feel introp that even then it is converging, then you might have to graft and then come back after 6 months to do the 2nd stage ACL. If it is ideal position, then you can go ahead and just use the same tunnel. Maybe it will become a bit wider, but that's okay. You can always, use a little thicker graft. If the dilation is more than 14 mm, then no kind of fixation is going to work. Then best in such situation is to graft it and come back after 4 to 6 months once the graft has completely healed. And this remains fairly true for both femoral and the tibial tunnel. So in revision ACLs, where we are not talking about the infective situations, mostly ACL reconstruction, this slide is the key, that where is my tunnel? And this has to be done only with the CT scan. Unless and until on an X-ray you see straight away it's a transtibial reconstruction. Okay, then it's a different issue. Otherwise, if it is the transportal tunnel, then you have to do with the CT scan to figure out where exactly is the tunnel. Pre-op counseling in all these patients are important. You have to give a very realistic outcome, no hunky-dory things. One must remember that outcomes are a bit unpredictable. You may go ahead with a plan that I will do everything in single stage, but it doesn't happen. Sometimes you have to come out and you have to do it in 2 stage. So you have to explain the patient that I may abandon the procedure also. The rehab is usually slow and may not return to the same level of sports. And this has to be absolutely communicated to if you are dealing with a sports person. If a normal person, it doesn't matter much because he won't be, returning to any high level sports, but the sports person, you must talk to them. The graft choices are plenty, but of late, what is emerging is, BTV has always been a very, very standard choice, but of late, what has emerged is the peroneus longus, because peroneus longus diameter can vary anywhere between 9 to 11 mm actually, even if you triplicate or quadruple. Quadriceps is also a very good graft because there also you have a choice to keep it something like, let's say 9 or 10. Contralateral the hamstrings are a good option provided your patient is not a very heavy demand patient. Okay, so they say yes, you can take it from the other side. Allograft in our country, not so much available. But whatever you do, it is important that you take the graft minimum of 8 to 9 mm because your tunnels would have dilated anyway. It cannot be now a tunnel of 7 or 8 mm. So you'll have a graft, the tunnel somewhere around, on a mean, it will be about 10 or 11 mm. When you put your scope, always look for any cyclops lesion, the meniscal tear and the cartilage injury, and you manage them as the standard protocols are. There has been enough discussion about them. I would not go into the details. If the alignment was a problem, please plan the high tibial osteotomy, do the reconstruction of the PLC or PMC if they are defunct or not perfect. So this is the case where the patient had a vertical ACL. You can see this is a vertical ACL. So I am not at all bothered. The tibia tunnel is in the right place, but the femoral tunnel, I have no problem. I can straight away go and make a new femoral tunnel. Just debride this graft, that's all. So this is one case example where it is a vertical tunnel. So you debride a bit of fat pad, debride all the, the ACL, clear up the fat pad, plica. So this is a bit short video, not really very important. Often what happens that these patients may be coming after, few months to few years, and the notch would have become very narrow. So in such cases, a notchplasty instruments should be around, and you must be sure that you are going to remove a part of the notch here. That is known as a notchplasty. Vertically, sometimes it could be V-shaped like this. So you might have to remove even from the top. And the ring curette is quite a useful instrument in such situation. Gently keep removing, and because once your graft is in, then it might be a little difficult to do all this. So do it beforehand only. So this is how you do the notchplasty. Make the notch a bit bigger. See that where you are going to place your graft, have you got enough space or not? If there's any loose hardware, you have to remove it. Sometimes, this was our own patient whose ACL had failed. This is the time when we were doing the Rigifix system from Mytech. It used to have a plastic sheath, so everything used to come out. So you have to remove all the loose hardware and then make the new tunnel. Now, as Raju was telling that, often, if you are not very sure, the outside in techniques are brilliant. You can actually decide that where exactly your tunnels are going to come and where you can make, especially if you have the old tunnel very close to the new tunnel. Okay, so in such cases, you can actually diverge accordingly. So in those cases, outside in is quite here you can see it's actually exactly in the place where I want, but there was no problem. So we went ahead and drilled with the same tunnel. But if it is very close, then yes, we are in trouble. The previous debris, from the previous fixation must be removed. So if this is a ethibond of the old, the graft, it has to be removed, and try to curate the wall a bit here and there. Okay, and try to get some vascularity back into the tunnel, which will help in healing the graft. Okay, so this we are just cleaning up the tunnel some more. And then you go ahead and do your standard ACL. So here we are not, changing any major plan. This is just the standard ACL. These reamers are actually quite good in getting rid of debris. You can use curettes to get rid of all, make the margins a bit, smooth rather than being very sharp, which can abrade upon to your graft. These are the debris. And same goes with the tibia tunnel. You have to remove all the debris, make the wall of the tibia a bit more bloody rather than being very, very smooth. This is the case where the tunnels are quite expanded. In such cases, if the tunnels are quite expanded, then we might have to put a graft and come out and then come back after 6 months. I think the ACL reconstruction remains a very standard technique. I don't need to emphasize upon that. All of us are well versed, but in all my ACLs, especially if I'm doing the revision, I would always use an additional post to give more and more security. Don't want, because the tunnels are quite dilated, and all of us remember the fixation, especially the distal fixation, can be a trouble. If you just rely upon the screw in the tibial tunnel, it can actually eventually become loose. So it is important that you can use a button, you can use a transtibial, under tibial tuberosity, you can make the tunnels, and you can use an implantless fixation, you can use a staple, but whatever you do, ensure that you have put at least one more distal fixation. IT band tenodesis, I think Deepak has covered in detail. I will not go into detail, but I personally always add this in my all revision ACLs, and I have not regretted, though my numbers are quite less. So let's say one case in 6 months to 8 months. So it would not give me a great, statistical idea that if I wouldn't have done, what would have happened. But yes, in all my revisions, I've done this, not to regret later, that's all. So in the rehab, remember, you avoid very accelerated protocol, you go a bit slow, protect the graft, treat all other conditions. If they have any, ask them to stop smoking at least a month or 2 in advance before the surgery, and return to the sports may happen only after 1 to 1.5 years, only when they have got complete, their strength back, and they have been able to do at least the, the single hop or the triple hop test, they clear, and your physiotherapist say that yes, he is ready to go back with the perfect proprioception. So patient selection, evaluation, pre-op planning, and meticulous surgery and supervised rehab are the key to success. Thank you.
Sir, you are always 100% in lectures. It's really, you make the life easy of all the audience and even in the faculties also. Just my question to you, as you said, if the tibial side diameter is less than up to 12 mm, you use single stitch. And which fixation on the tibia side then you use?
No, I would still use the screw, but I will always use an additional fixation. Additional fixation in form of I would keep at least 11, because now most of the companies would give you the 11 mm screw. So if let's say you have a 10 mm graft, okay, 10 mm graft, and you have got 11 mm screw, apart from that, you always use some kind of a non-absorbable suture to prepare your graft. Those non-absorbable suture, you put it either on the staple or the button, or you can use the under the tibial tuberosity. There is a technique where you actually loop the sutures around and you can just tie it.
Yeah, I use this secondary fixation always in my female patients with the primary ACL reconstruction. One more question regarding your STO with ACL. How first you with combined procedure, you do first ACL tunnels or you do after osteotomy? What is your protocol?
So what I do, Rajiv, I finish the arthroscopy. I finished the femoral, this graft harvest, because the incision is almost the same. So if you are taking the ST, let's say, okay, so you harvest the graft, then I prepare the femoral tunnel, because with the graft harvest diameter ready, I know exactly what I have to prepare in the femoral tunnel. Femoral tunnel is done, okay, and then I finish my STO. After finishing the STO, then I do the tibial tunnel, and then I pass the graft.
Okay, fine. And specific any plate, because sometimes if you use Tomofix, you find your anterior screw is encroaching upon your ACL tunnel. Then how you manage this?
I most of the cases, 99.9% cases, I've been using the Arthrex plate, the wedge plate, and it has got it's an angle plate, so I can always direct it a bit posteriorly. So what I do, I usually put the first anterior screw. Okay, and then I know in the image that, okay, this is little beyond 43% of the MS line. So I know that it won't come in my view, and even if that happens, I can always, redirect it a bit more posteriorly. And that plate usually has to be placed, remember, more posteriorly to get, the trapezoidal form. If you place that plate too anteriorly, you actually end up in the slope alteration. So that plate has to be actually placed too posteriorly. So usually it doesn't come, but yes, once it did happen, in that case, you can always change the direction of the screw. Because your Tomofix doesn't give you that liberty. It's a fixed angle. Nothing will happen. Yes.
I think the Arthrex plate is much handy with a combined procedure.
Yes.
Any question from the faculties to Dr. Vivek?
There is one question from Dr. Nicholas Antao in chat box. Role of HTO in SONC, spontaneous osteonecrosis. Vivek, you can take this.
I have a slightly, actually there's a lot of recent debate and question about the SONC, whether the SONC really exists. What people were thinking 5 years back, SONC, in my own case, I would admit today, in my own case about 4 years back, I dismissed him as a SONC. You know what it was actually? It was actually the root tear. Because root tear can sometimes produce extensive edema, and you get, mesmerized with that edema. Oh, this is song. Patient came back after 3 months. He said, I had put him on, all these, these bisphosphonates and some medication. But he said, doc, there's no improvement. And that time, again, I checked the MRI. I said, oh my God, it's a root tear. I prepared his root, his song disappeared. So I don't know. I have no experience in STO. I think maybe other esteemed, Raju, Jaya can throw some light on this.
Raju,
I personally have no experience of HTO in SPONC, and my limited reading of the literature also tells me that I don't think it's of any considerable benefit.
Jaya, because he will be talking on HTO today. Yeah, unmute.
No, I don't have any experience.
Okay. Any more question? I think Jaya, you can share your screen as we are getting late and. Vivek sir, one last question. While how you advise your if your revision in your high demand patient, for example, if he is IDPP man or he is a sports player, when you advise them to go back to sports, is there any role of MRI in follow-ups or how you decide?
Yes, Rajiv, very valid point. I think off late it has become the the trend, or you can say kind of standard of care, that in high demand athlete or the people who really want to go back to the sport, two things are important: clinical assessment and radiological assessment. So clinically they should have all those the better quadriceps strength, full range of motion, no instability, and triple jump, triple hop or single hop test should be negative, and your physiotherapist must certify that he's fit to play. Number one. Number two, the MRI must say that structurally the graft is intact and there are no other lesions. So then
sorry to interrupt you. Is there any role of signal intensity changes if it is comparable to PCL, whether it is a 50%, more than 50%? Does it really matters? Because a lot of literature now is coming with MR correlation in ACL ligamentization.
So we do it at 1 year, and 1 year it's almost the same as it is, athlete looks, naturally. So I have not read it off late any, much literature. So I don't think I'll give any wrong comment here, but the MRI is done usually at 1 year.
Yeah, true. MRI at 1 year and 2 years, and at 2 years, the ligamentization, if we want to say it is the right time at 2 years. Then the question comes. I think Dr. Jay is ready.
There is a study by, I think, Erickson et al. Okay, many years back. They actually said that the human ligaments, they continue to ligamentize up to 2 to 3 years. Yeah, and it was basically it was Freddie Fu who in I think in Goa conference, he said, I'm sending all my athletes back into the sports at 6 months. Then when he came to, I think 2015 to our Roshan's course or PSC, one of them, then he said, no, I'm sending them at 1 year.
This is what I am going to ask you. Why we ask our patient, you can play your sports at 6 months, 1 year.
No, I never say that, Raju. Yeah. I never tell them. I send them wherever you have read, you can ask the same surgeon to do, or you can follow the same website. My patients, because my boss Shripati Rao, he sent his patient to sports never less than 9 months. Never. Even in those days.
Yeah, I agree.
Can I go ahead, Rajiv?
Yeah, you go ahead.
Yeah, good evening, everyone. Thank you, Dr. Rajiv, for inviting me. So I'm going to talk on the medial opening wedge proximal tibial osteotomy for varus knee. So the indication in osteoarthritis in varus knee is mainly you have to consider the patient should be very active individual, and the age in Western literature it is less than 60 years. But if you take an Indian patients, you can consider 55, less than 55 years, and there should not be FFD of more than 15 degrees, and there should be at least 90 degrees of flexion from zero. And don't consider a high tibial osteotomy for the patient who is having moderate to severe patellofemoral osteoarthritis. Patients who comes back after your osteotomy, they will have continuous pain of patellofemoral osteoarthritis. They will blame the osteotomy. So don't consider these patients. The contraindication for this osteotomy is lateral compartment should be virgin, and you can do a MRI and to know the virginity of the lateral compartment. And if you have a doubt, you can go for the arthroscopy. And you check for the smoking. That is another contraindication, relative contraindication, and symptomatic patellofemoral joint and inconsistent pain and inflammatory osteoarthritis. These patients will, this is a global disease. So sometimes they will they will have the lateral compartment after your osteotomy. So don't take these patients, and obese patients who is having a BMI of more than 30, and again flexion deformity and instability of the joint more than 1 centimeter lateral thrust, and more than 20 degrees of correction. Don't go for the medial opening wedge osteotomy, and the lateral meniscus should be good enough to take the weight. So planning is very important for the medial opening wedge osteotomy. The correction is in tibia or femur, or if it is more correction is needed, you need to share the osteotomy in the tibia and femur, and you need to draw lines in the mechanical axis, anatomical axis, and find out the correction angle, and use the implant, correct implant, as Vivek told, the Arthrex implant. When you have the ACL and the medial opening wedge osteotomy, you need to have an implant which gives the way for your ACL reconstruction. And bone grafting, there are literature says the bone grafting not needed for the patients who are going for the medial opening wedge osteotomy, even though they have the 14 mm of opening. So you need to have the standing long leg 3 joint film, and check for lateral compartment. And our goals of correction is like anatomical valgus, normal anatomical valgus, normal mechanical axis, varus. And these people, Dugdale and Miniasi has proposed the 60 to 70% of the tibial plateau where your line of correction has to go through. And the most popular the method of correction is the Fujisawa point, where there is 62.5% from the medial to the lateral, and he has proposed this point to be taken for your mechanical axis correction. So there are 3 methods of calculating the angles. So mechanical axis, anatomical axis. So you need to remember these angles. That is a mechanical medial proximal tibial angle, that is 87 degrees plus or minus 3, and lateral mechanical distal femoral angle, that is 88 degrees plus or minus 2. Lateral distal femoral angle anatomical, that is 81 plus or 2. If you have a sagittal plane deformity, you need to take the sagittal normal angles. So the Fujisawa point, he has proposed the 62.5 from the medial to lateral, and again the Murphy has proposed these points, that is a 1/3 from the 30 to 40 from the midline, and 2/3 depends on your cartilage damage, whether bone to bone damage or 2/3 loss of bone or 1/3 bone loss or the no loss. Depends on that, you can correct the alignment. So this is one of the case, 50 years old male patient with unicompartmental osteoarthritis. Sorry. Sorry, 1 second. So first thing is, sorry, I will go back. So you have to, so this patient is having a 10 degrees of varus deformity, and the knee ROM was 0 to 110 degrees. So this is a perfect patient for the medial opening wedge osteotomy. So this was the preoperative planning, and the angle of correction was 10 degrees, and the 10 mm wedge I have taken for this patient. So I kept the patient under the C-arm, and I stood on the opposite of the limb, and kept the some elevation, because so our joint, my joint should be perpendicular to the C-arm. The next step is soft tissue and bony landmarks has to be marked, the patella and patella tendon and tibial tuberosity, pes, and the posterior margin of the proximal tibia and joint line. So this is the MCL. So this will be the MCL. So that my cut will be here. So in the mid of the medial joint, medial tibia. So this can be incorporated later with the, if the patient requires the TKR in the later date. So some people, they will give a oblique incision, but I do a midline incision in the medial part. So there will be biplanar incision, biplanar cut, this vertical cut, and the ascending cut like this. And I put a pin, prophylactic pin. So this gives safeguards the proximal tibia, and at the same time, if the fracture propagates intra-articularly, so this I can replace with the cancellous screw. So I am submerging under the skin. So once I submerge under the skin, then I will take the incision around 5 centimeter in the midline on the medial part, just centering the semi-membranous, semi-tendinous and gracilis. I elevate the periosteum and find out the semi-tendinous and semi-membranosus, the base. So this area, this angle will be my vertical osteotomy area. So this I will find out. Then subperiously, I will elevate the MCL. So some people, they do osteotomy just below the MCL to spare the MCL. And if the angle of correction is more, I do my osteotomy below the MCL. And if the angle of correction is very less than 10 degrees, I do a superior elevation of the MCL. Because if you correct more angle, there will be more compressive pressure in the medial compartment. So if you are correcting more angle, you need to do a MCL sparing osteotomy. So once I have taken that is, so only distal part I have erased. So once I did that one, and then I put in a guide wire parallel to the, so towards the tip of the fibula. Once that is done, then I will go with the second wire, because between the two wires I am going to have my saw, so that won't touch the posterior cortex or anterior cortex, so it will be safe. So once that is done, this is a vertical osteotomy, and then so you identify the ascending osteotomy. So once this is a vertical osteotomy has been done with the A wires, then you go for the mark your ascending osteotomy. That should be 110 to 120 degrees to the vertical osteotomy. Once you are done, you 2/3 of the medial side has to be done with the saw. So saw blade has to be parallel to the joint line. That is very important, because when you are opening, so that may give a slope change. So if you have your saw in the parallel to the joint line, that will open up naturally with the parallel to your plateau. So this is a very important step. Once you have done that one, and I stock the chisels, different size chisels. These are available with the Orthorex, and try to open the posterior cortex. That is a very hardest bone. So try to open with the chisels. Once that I did, then I try to cut the ascending osteotomy. So you can see the slope cut. So in between, you have to check the patella and tibial tuberosity, whether it is safe or not. At least a 1.5 centimeter should be there. So try to open the osteotomy. Then, so in putting the chisels in between the two chisels, that is very important because you are not going to damage the bone. Once you have done that one, so you see here till 2/4 of the three-fourth of the this length I did with the osteotomes and the saw. Then remaining 1/3 is virgin, so that this will give a hinge, so that I can open the medial side with the help of this hinge. So if you see here, so that there is an opening. If you see here, that's slowly opened. Once your assistant gives a valgus, so this, so take more time to osteotomes and so sometimes you can have these jocks. These are available with the Arthrex, so that the marked jocks, there are you can see the 5 and 7.5. The depends on this width, so that slowly you can open up the medial osteotomy. This is a laminar spreader. You can use put the laminar spreader at the posterior medial corner, so that is the bone is the thickest part. So this one has to be put here. So then the remaining part you can put this plate. So try to open that one in a controlled manner. So once that's opened, you can measure how much is the opening. Once that is done, you periostally erase the distal part to have the plate. Then you fix with the plate. This is a Tomofix plate. So there are comparative studies between the Tomofix plate, the plate with locking plate with the wedge plates. The Tomofix plates having a better results and better, lesser complications. So that spreader is not coming in the way, just it is in the posterior medial part. Once that is done, the next step is So we fix distally and then check the alignment. So if you see here, this is the lateral part, just lateral to the lateral eminence, that is almost at Fujisawa point. Once that is done, so that is done. So this in the Tomofix, this screw is a small screw, so which gives the periosteum on the there is a place between the plate and the periosteum. So the periosteum and the M cell will be slided under this plate. So in conclusion, in proximal tibial opening wedge osteotomy, the patient selection is very important. Patient should be younger than the 55 years. Patient should be active, and you have to plan how much is that, what is the deformity, how many planes the deformity is there, a single plane or biplane, and axis of deviation has to be calculated, angle of correction has to be calculated, and choose the implant which is the best for that, because if you have a open weight jaw osteotomy with the ACL, you need to have a different implant. If you have only isolated medial open weight jaw osteotomy, you need to have a tomofix type of implant. So bone grafting are really not needed. If it is more than 13, 14 mm, then you can go for the bone grafting. So thank you very much.
Pankaj,
a very nice presentation, Dr. Reddy. May I ask you a question about what is your protocol to prevent increasing the posterior slope in your patients? What is one most critical step which you would recommend to all the viewers to prevent the increase in posterior slope in a medial opening wedge osteotomy?
Yeah, that is a complication because you know that the osteotomy most common complication. You won't have the control on the proximal fragment and distal fragment. That has to be keep in mind throughout your procedure. And if there is a ACL deficit or ACL is lax, then it is okay for the medial wedge osteotomy. That will give sufficient this one. But you have to see the width, how much is the opening anteriorly, posteriorly. That you have to measure till the end. That is very important.
Correct. So I would also like to add that superficial MCL should be released as much as possible, even underneath the pes, and that's what that would allow you to open the osteotomy more in the posterior side rather than the anterior side. And one question generally to all the faculty members, especially in combined procedures, where we are using a plate which has a variable angle, as Dr. Pandey was telling us. So what happens if you sustain a lateral hinge fracture in such a situation? How do you deal with it?
So there are, I think, two things. One is if, it does happen once in a while, especially when you try to, whatever you do, in out of, let's say you do 10 HTOs, 1 or 2, there will be some extension. If that happens, there are two issues. One, you can go ahead and put 2 staples on the lateral side. Second is you can straight away switch over to tomofix, because when you put the tomofix and especially put the distal yellow screw, it actually closes the lateral hinge.
That's correct.
Okay, and rarely you may have a situation where you may have a split tibial plateau, which is very, very rare. Then in that case, you can pass one cannulated cancellous screw. But you are very true, and you have to be very, very watchful. There are sometimes very small hidden lines which just extend to the lateral tibial plateau. So one has to be very, very cautious. It happened with me once, and I, did not actually realize. Only after 6 weeks that line was apparent. That woman was a bit porotic, thyroid, and then it went into actual non-union. So one has to be very watchful.
I would agree, and rather where we are attempting a slope correction or a change of slope, there it is even bigger possibility. And to add to Dr. Pandey's statement, we can also do 1 screw above and below and do a tension band wire over that just to close the lap.
And I think this KY technique is good, Andy. Dr. Jaya showed us. It is again a good way to avoid such type of fractures on the lateral side. One more question to Jaya. How much correction you, if you have bone-to-bone arthritis, still you go with the STO? And what is your maximum limit of correction?
So maximum limit of correction is 14 mm in the 14 degrees in the tibial side. If it is more than 14, you have to split the wedge towards the one for the femur and the tibial side.
Do our faculty advise STO in bone-to-bone arthritis? I can put this question to Dr. Raju.
I would probably not advocate on bone-to-bone arthritis. There, I think more replacement kind of a procedure, maybe along the lines of a UD condylar, maybe a bit more preferable. But I would generally do it probably in stage 3, never in stage 4.
Once bone-to-bone arthritis on the medial side, you can just think about the lateral compartment.
And one more question. Do you advise arthroscopy before doing STO? Because if there is a concern on the lateral compartment, which is a hidden lesion, and it doesn't come in the MR scan, do you always go with the arthroscopy before planning for STO?
Yeah, if it is really patient is asymptomatic on lateral side, if there is a tenderness, if I have a doubt on MRI, and then if reasonably it is good on MRI, then no need to have arthroscopy.
Because what I saw in a grade 2 and 3, if I planning for STO, it's not a sometimes it is a root tear also, and does in that scenario root tear helps in, or only STO is enough? You can leave, Dr. Vivek, if it is a combined STO with root tear.
Actually, there are two questions what you have, progressed to. One is, arthroscopy, HTO with or without arthroscopy, most of the studies have found no difference, number one. Number two, there are studies also which said that whether you repair the root or you do not repair the root, still there is no difference, okay? Because root itself, if you see the studies which have emerged in last 5 to 7 years, they find that the only 30% heal completely, 30% partial, 30% do not. So having said that, all of us, most of us who are watching this, and maybe others who are on the audience, all of us are arthroscopic surgeon, and I find that there's absolutely no harm putting a scope, quickly going in, cleaning up the mechanical things. If there's a root tear, what's the harm? Fix it. It's okay. I would not leave it like that.
I also follow same the principles. Don't leave it, repair. How much heal doesn't matter.
It doesn't matter. Anyway, I'm doing it. I'll just do it. That's it. And if there are studies also which say, Deepak Goyal, if you ask him, there are studies which say when you actually decompress the compartment, medial compartment, the fibrocartilage automatically starts growing. But there's another group which says that you can actually do the microfracture on the medial femoral condyle, and that helps in acceleration of the growth of the fibrocartilage.
Jaya, for the audience, how you measure your correction? It's 1 degree, 1 mm. How you decide?
1 mm till 14 mm. It is till 10 degrees. It is 1 mm. More than that, you need to have the 1.5.
For example, if you have 10 degree varus, how much you are going to open?
10 mm wedge.
Okay, fine. Pankaj, yeah, you want to say?
Yeah, just to add to it quickly, our audience can refer to the Hernigu chart and measure the proximal tibial dimension. If it is 56 mm, then of course 1 degree is 1 mm up to 14-15 degree. But otherwise, you can refer to that table and decide how much mm you have to do.
Okay, now we can have our next speaker.
Yeah, so we have Dr. Prathamesh Jain, and he is going to talk to us about the patellofemoral instability. Dr. Prathamesh, over to you.
Yes. Can you see my talk, sir?
Yeah, it's clearly visible. Yeah.
Okay. So it's just an out-of-box talk. We all are arthroscopic surgeons and we are doing a lot of MPFL reconstructions. So this is something new that we have just developed, and we are glad to share that this has been accepted for publication in Arthroscopy Techniques. So I'll just present a case. It's a young 19-year-old male patient with recurrent episodes of patellar dislocations. There is no significant bony abnormalities. The trochlear morphology is normal. TTTG distance is within normal limits, and the patellar height is normal. So by and large, a straightforward soft tissue problem leading to patellar subluxation or dislocation. So if you see on this, so you can see that there is a patellar subluxation on the lateral side, and we did a procedure which is an MPFC advancement procedure. This is called as mediopatellofemoral complex advancement procedure, and you can see that there is a good stability which we can achieve. So this is basically the paper that we have published, and probably it will be published in next 2 to 3 months. It is accepted. So it is basically it believes it arises on the concept that patellofemoral early or low-grade patellar instability or low-grade patellar dislocations are basically due to soft tissue problems. And there are two ligaments which we need to focus on. There is one ligament which is called as an MPFL, which is a mediopatellofemoral ligament, and there is now one more ligament which is described and which is now recommended that we do a MQFL reconstruction, that is medial quadriceps ligament basically. So it goes from the medial femoral condyle to the quadriceps tendon. So MPFL and MQFL are two ligaments which are responsible for the medial restraint. Now, this procedure is, as compared to an MPFL reconstruction, is more biological, more isometric. It can be done in an open physis patient, and it is devoid of the problems of MPFL reconstruction, typically the patella fractures and the over-constraining of the medial patellofemoral cartilage. So what we do is we put an incision on the medial side. We release the first layer, the retinacular layer, and without violating the deeper capsulo-ligamentous layer. So we dissect it in two layers. The outer layer is erased, and we identify the inner layer. So once the outer layer is identified, we release the inner layer, the capsulo-ligamentous layer from the patella, and then we just will identify and outline whole of the capsulo-ligamentous layer. And this capsulo-ligamentous layer goes from the lower part of the patella to about 1 to 2 centimeters to the quadriceps. So it involves the parts of both MPFL as well as the MQFL. Now we insert 2 suture anchors on the patella, and then we will pass the sutures from the suture anchors into the capsulo-ligamentous layer, and this is basically for the advancement. After that, we shuttle the suture limbs, and then we repair the sutures. So there are 2 double-loaded sutures. So in all, we have 8 suture limbs. So 4 knots are tied on the capsulo-ligamentous layer, and this is basically advancement. And then we make it double row by incorporating it onto the patellar periosteum. So once we do that, we will realize that there is a very strong medial restraint which has been built up, and without any over constraining, because this is the body's own graft. So there is no chances of over tensioning, and there are no chances of anisometry here. This is the final picture, and then we close the musculoretinacular layer in the usual fashion. So this is a small video that we have prepared. So this is the patient, and we can see that there is a significant lateral translation. This is a medial incision. The advantage of this technique is it is very simple to perform, and there is a very low learning curve in this particular technique. So the incision is about 2.5 centimeter top of the patella, and it goes up to about lower 1/3 of the patella, and we make a reverse L-shaped flap in the capsulo-ligamentous layer. And once this flap is elevated, we will be there onto the capsulo-ligamentous layer, that is the 3rd layer. We usually use 2 vicryl sutures to mark this flap. Now this dissection is to be from distal to proximal, not from proximal to distal, because these 2 layers are adhered in the proximal part. So start your dissection distally and go proximally. We use 2 vicryl sutures to retract this flap. And now this flap is, and now you can see that this is the MPFL. So normally MPFL is basically in these patients' legs, and this is the MPFL. You can see that MPFL is seen there. And what we do is now we'll release that. So this patient has a recent episode of dislocation. So he had a hematoma as well. And then we resect this layer about 2.5 centimeters top of the patella to 1/3 of the inferior part of the patella. And this is the capsulo-ligamentous layer. It includes MPFL and MQFL both. And now what we do is we use peak anchors, 5.5 mm, 2 peak anchors. And we use inserter here. We use 2 double-loaded peak anchors, 5.5 millimeters. And then this layer, this is the capsulo-ligamentous layer. this layer is sequentially advanced. So and this has to be passed as deep as possible. We want to advance it as much as possible. And this is usually around 2 to 2.5 centimeters deep. The bites of that is 2 to 2.5 centimeters deep. Once all sutures are passed, we'll just tie this layer. So all these 4 sutures are now tied, and now we will do a double row kind of a repair by including this in periosteum of the patella. So the respective limbs are tied to each other here. And this makes a very, very solid repair. And there is a significant improvement in the lateral laxity. And the advantage of this technique is you cannot over-tension it because it's sort of a natural tissue. So it will never be over-tensioned. And there's a very less chances of over-tensioning of the medial patellofemoral. And usually we can start the mobilization the second day. The outer layer can be closed in the usual fashion by standard grafts. And this is patient's 1 year follow-up. And we have done post-op MRI scans after 1 year, and you can see that there is a very nice healing. You can see the suture anchor, and there is a very nice healing in that particular area. And you can see a very thickened kind of MPFL tissue over there. These patients do very well. I have had a short series of around 13 to 14 patients in which this procedure we have done so far. And luckily, so far, there are no redislocations. The indications are basically recurrent patellar instability with confirmation for lax medial restraint without bony abnormality. This is an important prerequisite. You should not have a bony abnormalities. The TT-TG distance, there should be no patella alta. And you can do it in acute primary dislocations also when the MPFL tear is on the patellar side. The prerequisites, as I told you, is trochlear dysplasia grade A, TT-TG distance less than 20, patellar caton Deschamps index less than 1.2, normal Q angle, normal hip anteversion, and no rotational deformities. The advantages of this particular procedure, it is an anatomical procedure. There is no or minimal chances of over-tensioning. There is no need of donor graft, no chances of patella fracture. It is a simple procedure and can be reproducible even in patients with open physis. Early range of motion can be started. It is easily reproducible. Many of our surgeons who come to us, I see it once and they can do it on their own. No requirement of intraoperative fluoroscopy. There are some shortcomings. It is usually contraindicated in cases of generalized ligamentous laxity, and in acute primary patellar dislocation with femoral sided injury, it is not useful. Important things is you need to do a careful scrutiny of MRI section, specifically in acute dislocations. Important operative tip is you have to preserve the capsular ligamentous layer while incising the musculo-retinacular layer. You have to do a 2-step dissection. You separate the musculo-retinacular layer from the capsular ligament layer with a careful dissection. Go from distal to proximal. You tag the superficial flap. Use double-loaded suture anchors. And then you tie the suture limbs distal to proximal. There are some pitfalls. The separation of musculo-retinacular layer can be difficult. This is the most difficult step in this procedure, and specifically proximally because they are very closely adhered. So the key is to start distally and go proximally sequentially. Occasionally there can be a MPFL which is very flimsy or severely attenuated, and in that scenario you may have to do a MPFL reconstruction. And usually I do not attempt to advance the superficial layer because then that can lead to anisometry. And nowadays we are combining it with the other procedures also. So if there are bony abnormalities, we do like a Fulkerson or TT tibial tuberosity osteotomy, and we combine this with MPFC advancement on the soft tissue femoral side as compared to a traditional MPFL reconstruction. It's a new approach. By this, many cases of MPFL reconstruction can be avoided. It is more isometric, very low learning curve, and easy to reproduce. And this is a small algorithm that I usually do. If there is a type A, type C trochlea, low Caton Deschamps index, less than 20 mm TTTG, I do a soft tissue procedure. Above that, you can do a tibial tubercle osteotomy for type A and type C trochlea. Type B and type D trochlea, you can add a trochleoplasty, and then you can add both of them if there is more type B or type D trochlea with TTTG more than 24. And if there is a significant patella alta, you can add a distalization. I'll just finish it up here because we are getting late, and now the talk is open for any questions. I am sure it is a new concept, so there must be a lot of questions.
Any comment from the faculty members?
Prathamesh, yes, very nice technique. The very first thing, it may seem very basic, but I'd like to know the key differences between this particular technique and the medial imbrication that was classically described, the medial rigging. So
the most important thing is the medial imbrication will not separate the two layers of MPFC and retinacular. That was basically, I think, the fallacy of medial imbrication. So the initially Campbell techniques in which we used to do a lateral release medial plication, what they used to do is they will cut the medial side in one layer and they will try to double breast the whole layer one by one. So what that does is that creates a sort of an anisometry, because here if you see what we have done is the concept here is basically I have taken it from the ankle part. If you see that Brostrom procedures in which we do an advancement are more successful as compared to a tenodesis procedure in which we use a peroneus. So the same thing is applying here. So when I was doing my MPFL reconstructions, some of my patients are good, but some of my patients were not doing that well with MPFL reconstruction, typically because of the isometry. Some may have a terminal loss of flexion, some may have a medial patellar overload kind of a syndrome. So this was the main thing that I started this. And the other thing is that MPFL is basically a capsular thickening. It is not a ligament. And usually most of these cases in which there is a patellar dislocation, the MPFL usually will heal. It will heal in a laxed position. So most of them if you see an acute patellar dislocation, you will see that there is a disruption of the MPFL, and the same patient you follow later on, like 3 months, 6 months down the line, you will see that the MPFL is healed and it is thinned out. So basically it will heal in a lax or a thinned out position. That is the natural course of healing of MPFC complex. The other thing, if you see the recent talks by Fulkerson also. So he usually, he is now putting more emphasis on the MQFL reconstruction as compared to a MPFL classical reconstruction. And they say that you pass the graft onto the quadriceps graft and not to the patella. So that is MQFL is important medial restraint as well. So by this technique, we are including both the MPFL as well as the MQFL, and doing the advancement of both of these structural ligaments. So that makes it a more stronger and more isometric kind of a repair.
Any more comments, Dr. Vivek?
I think it's quite nice, seems very logical, but what I have failed to understand in this whole thing is, see, this should work only, according to me, only in the cases where there is a kind of patella side tear of MPFL, which happens in the kids. Because if you also said that your indication is recurrent dislocation of patella. Okay. Now this patient of yours was 19 years. In large majority of the patient who are adults, 19, 20, 25, whatever, if they get the tear of MPFL is from femoral side. Now, if there is a femoral side tear, imbricating the medial end of the patella, how it is going to benefit? Number one, acute, I can still understand some fibrosis, but in chronic, how will it help? I mean, especially in an adult, if you're talking of an adult, in kids, I can understand, because kids, most of the time, the tear is from patella side. Okay, it's not from the femur side. So when you imbricate, it's going to, give you a very robust repair.
Sir, in all of these cases, if you see your healing patterns, so this MPFL is a tissue which usually heals. That is what our philosophy is. So even if there is a femoral-sided avulsion or femoral-sided injury of the MPFC, it will usually heal. Because if you see your follow-up MRIs, if the patient who is conservatively treated and you're not operated, you will not see that deficiency of the MPFL on the femoral side in your follow-up scans. So if you serially follow up your MRI scans, like you say on day 1, 2 months, 4 months, 6 months, you will see that there is a femoral-sided MPFL avulsion in, let's say, in acute injury, like initial 15 days or a month. And if you serially follow them up, you will see a nice kind of a MPFL sheath, which is formed in a natural healing course. So in its natural healing, it usually tends to heal in a lax kind of a over lengthened course. This is similar to what I understand or what I presume like in an ankle. So if you have a recurrent ankle sprains, if you just do your dissections, you will have a lax ATFL. You will never see an ATFL which is torn.
Very true.
Like if you are doing a prostrom, you will not see a ATFL which is torn. You cannot identify that this is a tear in ATFL. It's basically a lax capsule. So similar concept we have applied in this particular.
Okay, Dr. Tatmesh, just one more question. If you have to perform a bony procedure also, first you do bony and then come to the soft tissue procedure?
Same. So if they're like in that conventional teaching, we used to do a tibial tuberosal osteotomy along with an MPFL reconstruction. So what we do is we do a tibial tuberosity osteotomy, and then on the patellar side, we do a MPFC advancement instead of doing a MPFL reconstruction.
And tips to not to constrain the joint because stiffness is the biggest problem.
This surgery cannot over-constrain the joint.
And any tips if the audience want to do MPFL as MPFL reconstruction, how to avoid over constraint, and how is any way of clinical while doing surgery? Is there any clinical measurement?
So in the classical MPFL reconstruction, yes, there are chances. If your tunnel is non-isometric, if the femoral entry point is a little bit, or I'll say proximal or anterior, you may lead to a over-constraint kind of a graft, which can lead to flexion deficits and which can lead to medial patellar pain syndrome. So that was actually the reason why I shifted to this technique. I was doing MPFL reconstructions till 2017. And by going on to the ankle philosophy and then doing 1 or 2 cases in which I had done a primary case of acute dislocation, then I find this technique to be quite rewarding because the patients did very well over the time. So in approximately last 3 years, I have not done a single MPFL reconstruction. I am doing only this technique.
As other faculties doing MPFL reconstruction, do they find stiffness in the post of rehabilitation? How do they manage them? Because all the females, I think maximum patients are females and young females, and the cross-leg sitting and squatting is a really big challenge. How do you manage? You advise your patients for physiotherapy? How strict you are? Just one of you can answer.
Rajesh, you were asking about the tightening. The PFL, you put a hemostat or artery, something. That is how we do. We put a hemostat beneath the tendon and then we tighten it. So we have some laxity. So we have some 1 centimeter of excursion on extension, and the idea is that the patella engages at 30 degrees. At that time, the laxity should be less. Otherwise, if the fixation is good, I think we should mobilize them as early as possible. And I have not seen stiffness as such in the MPFL cases. I have never manipulated them as such till date. And generally, they do well.
Perfect. I think it's more than 3 hours. We can conclude. Dr. Sridhar, are you there? You can give a closing remark.
Yeah. You can hear me, Nasif. You can hear me?
Yeah, we can hear you.
Yeah. So thank you so much. I thank all the faculty and the moderators. It was a very nice discussion, especially HTO, revision ACL part and the meniscal tear. So it was a very good discussion between the panelists also. So I thank all the faculty for taking out their time in their busy schedule and giving their valuable suggestions. So over to you, Raj.
Dr. Bagaria, you want to say something? Okay, thank you. Thanks to my all the faculties for sparing time. It's more than 3 hours, and it's really it's eye opening and for the nice discussion. Thanks to audience also. Thank you. Thanks a lot.
Thank you, Raju.
All the best, Raju Ishwaran. All the best.
Super.
Thanks. And on a concluding note, I would request all the IAS members to participate in the voting, and best of luck to all the candidates.
Yeah. My vote for you.
Thank you.
You say directly, give me vote.
Thank you, Raju.
I am learning to be politically correct.
Absolutely.
Okay, guys. Wish you a great year ahead. Thank you so much for
Thank you, sir.
being here. Thank you.
Thank you.
Thank you.
Thank you, everyone. Thank you.
Thank you so much.